xem.
Good evening, Dr. Ahmed. Can you hear me?
Yes, Doctor.
another 2-3 minutes and we will start. Okay. Good evening. I am Dr. Gültekin Bekirova. I am intensivist in King Saud Medical City. So all of you, welcome to second day of online ICU course for non-ICU physicians. In the program today, we have 5 lectures which will be presented by ICU consultants. First lecture will be presented by Dr. Ahmed Kukhel. He's our ICU associate consultant. He have difficult task today. He is responsible for technical support of the course, as well as he will present very important ICU topic, shock, and he's doing great job actually. And welcome, Dr. Ahmed. You can start your presentation, please.
Thank you, Dr. Gültekin. Assalamu alaikum. Thank you, everybody, to enjoy us in our course for non-ICU physician with this surge plan of COVID-19. So today we will discuss about shocks and fluid management in the COVID-19 era. So we'll start initially with our learning objective. We will discuss about fluid responsiveness and definition of shock, pathophysiology of shocks, the types of shocks, what is the clinical manifestation of shocks, and some therapeutic modalities of shocks. So here if we discuss about the fluid resuscitation, double H here. So the fluid resuscitation actually done to increase, what is the aim of fluid resuscitation? Initially, our aim to increase the systemic blood pressure. This is the most important for that, because when we give fluids, it will increase the venous retain, it will increase the cardiac output. This is the simple idea. But excessive fluid resuscitation can cause hemodilution, which can decrease the cardiac output and increase the capillary pressures. And the edema, which the more fluid will be given, so more edema, and it will decrease actually the vascular integrity and increase the problem of the edema, pulmonary edema. It can be desaturation, faster respiratory failure, which it can critical outcome. It can be from the aggressive fluid responsiveness. So if you can see here the relationship between fluid loading and the complication, because if we go for under resuscitation or over resuscitation, or if we can go the balanced resuscitation. So it's very important to assess how is the patient volume status and what we should give him the fluid. If you go to see here, there is the under resuscitation, which increase the complication as in the post-operative, even not in post-operative, it's the same. But here, under resuscitation, increase the complication but over resuscitation also increase the complication. But if we are in the balance, we will be in the better area and the better area and better outcome. So what are the consequences of a general edema? So it can, which is the most critical part, impaired gas exchange. When you give more fluids in the alveoli will be, so defecting the gas exchange, more hypoxia, more CO2. So limited cellular oxygenation will be, because we are not giving a good oxygenation to the blood. So will be there is cellular oxygen problems, and there is impaired the wound healing, like the patient has been sore or post-operative, whatever, they will be impaired of the wound healing. And even there will be the risk for a new pressure source. So brain edema, which it can worsen the outcome, gut dysfunction, decrease the absorption, increase the residual volume, patient not able to get enough calories to compensate the high catabolic status with current infection, and increase also the intra-abdominal hypertension, which can lead to intra-abdominal compartment syndrome, increase the renal failure, which is it's catastrophic if it's happened. The other issue, myocardial dysfunction, more edema, more myocardial dysfunction, and risk of, as we mentioned, decubitus ulcer and impaired immobilization. So they will be less able to move and to give their own usual activity. So the early mobilization will be difficult with them. So here we will just discuss about the major complication after the open heart surgery. Here in this study, they are comparing two arms. This one arm, they are talking about the normal saline sodium chloride of 0.9% comparison to the plasma light, which is the called balanced crystalloid, like what we have the common ringer lactate. So if you go to here, the odd ratio, the odd ratio here is 1, which is below 1 usually in the any trials you are seeing. Just look to the odds ratio. If it is less 1, so it's preferable and the outcome usually it's better. But if it's more than 1, it's not preferred. So if we can go here, the below 1, they are favor of the balanced crystalloid, and which is going, all of them, they are going with the balanced crystalloid in this area, including the mortality is better, GI, renal, cardiology, respiratory, hemorrhagic, and major infection. All they are preferring to be favors with balanced crystalloid. And this was published in 2012, and there is later on another study. It was in 2018 with which called SMART trial, published in May, and also it's the same except it was in the cardiovascular. So just here we can give the scenario: a 45 years old male who has blood pressure of 80 by 40, receiving IV fluid, and his blood pressure is 80 by 40, lactate is 4. So what's the initial vasopressor support? Because the initial step, as the usual practice and the usual recommendation, you can give volume resuscitation, but you have to be careful about the volume resuscitation not to be or extra volume to be resuscitated. So you have to be in balance. As just to know, when we early patient in shocks, especially in the septic shock, the early stages, they are getting better responsiveness. But when we delay the procedure, the resuscitation, there will be less responsiveness. Even they are hypotensive. But for example, the patient starting in the septic shock in the first hour, you are giving a fluid, they will respond to the blood pressure usually better. But if you give after 3 hours, 4 hours, it will not be the same effective to the improve the blood pressure. So here, this is very important. So as we mentioned, as I saw here, most of them, they are selecting noradrenaline as the first line of option, and some they are saying adrenaline. Actually here, there is a recommendation to be, we will discuss it now. What is the appropriate answer? So how could we evaluate the fluid responsiveness? So there is a lot of modalities to assess the fluid responsiveness. There is something called static, and there is something called dynamic. Dynamic, which is more accurate, but static, it can give you like a shortcut of or just a snapshot what happened, what's ongoing at this moment, but it's not accurate that much. Like if you check the CVB, it can give you the idea, but it's static, not dynamic. And there is some confounders, like the patient who has right-sided heart failure, pulmonary embolism, all these pulmonary hypertension, all it can affect the CVB monitoring. So, but it can be used as a static monitoring. Even the inferior vena cava assessment, it can also reflecting the volume status, but also it is static. Lactate and the fluid challenges. Fluid challenges, now there is two modalities they are using, either to give mini fluid resuscitation code or mini challenging. So you can give 100 ml of fluid over 1 minute, then you can check the stroke volume. This is usually preferred to be done who has invasive monitoring like Pico machine or E1000. So it's better to get better reading and assessment. Otherwise, you can give 500 fluid and to reassess how is the improvement in the stroke volume and the blood pressure, the map. So usually these patients, they have A line. So from the arterial line, you can see the waves, how the reading is improving, and we see. The other, you can check also monitoring the lactate, because the lactate with hypoperfusion, because we have type A, type B. Some patients with the COVID-19, they have some renal, some hepatic failure, so they will be type B hyperlactemia. So the fluids, it will not be beneficial for them. Lactate not all the time. Hyperlactate means you have to resuscitate. Maybe you will harm them. And there is other causes of hyperlactemia, not only the liver, it can be microcirculation defect. So this is advanced, it's not our scope at this moment, but just keep it in your mind. So there is other differential for that. So the other modality is to assess the fluid responsiveness as dynamic status, like in ventilator, in expiratory occlusion, and or increasing the beat. Stroke volume, as we mentioned, pulse variation, pulse pressure variation, arterial line, we can monitoring how it will be affecting. So here, if we see how the passive reglazing, how it will be, the patient, he will be sitting in 45 degree, then without touching the patient. This is the most important. We should not touch the patient, because if we touch the patient, more sympathetic, it will give false positive. So you should not touch the patient. It should be just only the bed. From the 45 degree, you will make the head flat, and you will raise the legs 90 degree, 45 degree. So as we are changing the edge 90 degree, because here 45 will go down, the legs will be go up 40, so 90 degree. If there is improvement in the blood pressure, ideally after you return the patient, the blood pressure will be back as it was before. So this is called the fluid responsiveness at that time. But if you are touching the patient, you are manipulating with the patient, it's it will give some false positive results. The other issue here, if you see here between the abdomen and the legs, there is 45 degree. Why not to keep the patient in sitting position 90 degree, then just raise the legs up and to put him. Why? Because if it is 90 degree in the hip joints, the venous return will be low. So will not go, all the blood from the legs will go back to the heart. So it should be open by 45 degree. And by this maneuver, actually, it will 300 ml of blood will go back to the heart. So as you are giving boluses of fluid without harming the patient. So here again, 18 years old female admitted to the hospital electively for nasoseptal deviation. Actually, we can skip this for the matter of time. So just as we'll give another scenario. This is the patient admitted as a case of COVID-19 high score. and he has some lactate raising. So we go for the different assessment. We went for CVB, and we check also. It was here the CVB, not. It was around 10, and IVC. If you look here, the IVC you will go for subcostal view, and you will put the M node and 1 centimeter to 2 centimeter maximum below the heart side. When you see here the heart, it's pumping below it exactly at this junction between the inferior vena cava and the heart, 1 to 2 centimeter. Just you will put the line here, and you will see the M node. Here, actually, there is multiple way to calculate there is collapsibility index, or just to see how's the difference between them. Ideally, to see there's, if you look for this patient, is the distance in the first one 2.2 and the other 1.5 centimeter. So if you calculate the collapsibility index or the collapsing is less than 50%, which is not going with volume responsiveness. But remember, this is inferior vena cava is static, not dynamic. Okay, also here we go for fluid resuscitation. They give the fluid, but actually there is know that it's not that much improvement. And the pulse pressure variation also, it was not that significant improvement. Here another scenario. So this the first scenario, there is this patient has no he's not fluid responsiveness. In this picture, this is another IVC assessment. If you go for the IVC during expiration, if you can see globally without measuring, it's very significant how is the difference between inspiration and expiration. So more than 50%, which is going with as a static fluid responsiveness. Here, this is the pulse wave, how we can calculate the stroke volume variation. This is usually with invasive, we are using this measurement, so just we will skip it. Here, the other scenario, 72 years old male, he has obese, diabetic, hypertensive, history of ischemic heart disease. He was admitted as a case of septic shock. But keep in your mind, usually in the COVID-19, the septic shock is not that much common. So if there is shocks, you have to think properly what's going on, because not all shocks we are going with septic shock, because it can be cardiogenic, especially they have some of them, they have complicated with myocarditis and myocardial or cardiogenic shock later on in advanced stage. So keep in your mind about the other possibility before to label him as septic shock. But in this case, he was labeled as a case of septic shock. And intubated, the patient, he was in respiratory distress, hypotension, with altered level of consciousness. So here they did the fluid to check the fluid responsiveness for him. The CVB actually it was around 12. IVC not collapsing, lactate 2.8. Fluids also not there is no improvement with the fluid challenges. And the pulse pressure variation actually it was 11. Usually it should be higher for pulse variation. And even after passive leg raise test, there is no significant improvement in the blood pressure. So here we will just back to the fluid status and which types of fluid. And this is the trial. It was published in New England journals. So they are comparing between the balance and saline crystalloids. If you see here in this the trial, most of them the odd ratio below 1, except in 2 actually. Here in the cardiac, the normal saline, and there is a traumatic brain injury. So the outcome will be better with saline, normal saline 0.9. But the otherwise, balanced crystalloid is preferable. So here we will go to what is the definition of shocks. So definition of shocks, it's actually failure to deliver or to utilize adequate amount of oxygen. There is tissue dysfunction, and you have to keep in your mind, this is one of these 3 should be MAP less than 65, or systolic blood pressure less than 90, or decreasing blood pressure more than 40. So you have evidence of hypoperfusion, like altered level of consciousness, decreased urine output. There is evidence of hypoperfusion, high lactate. Also, there is some sign we can mottled skin. It can be there. In addition to that, it should be the blood pressure. There is a 3 parameters you have to keep it in your mind. Systolic blood pressure less than 90, or MAP less than 65, or decrease the systolic blood pressure more than 40 from the baseline, especially who has chronic hypertension. In addition, it should be the lactate is high. So the pathophysiology here in the COVID-19 about the shocks, usually, if you can, they are going for 3 stages. The initial one over the 7 days, actually they have flu-like symptoms, and 80% of them they will recover spontaneously with only supportive therapy. But there is in the mid stage, 4 to 7 days, it will be the pneumonia and the hypoxemia. Later on, they can develop the ARDS and cytothrombosis, especially who has high D-dimer, and myocardiomyopathy, and little evidence of hypovolemia. It can be there. So this is very dangerous stage, in the latest stage of after 8 days, and cytothrombosis is very catastrophic. Actually, if it's happened, it's poor prognosis will be, especially if there is also myocardiomyopathy. And so it just keep it in your mind. This is latest stage. It can be dangerous if not discovered early and punished early. The others can be complicated with the second bacterial infection, stroke, and myocardial infarction, or myocardial failure even. So just remember again, the shocks, as we mentioned, there is evidence of hypoperfusion with high lactate, or systolic blood pressure, as we mentioned, less than 90, or decreasing systolic blood pressure more than 40 from baseline, MAP less than 65. So now, what are the factors affecting the MAP? If you go to, again, to the calculation and mathematics, actually, how it will be, the MAP equal the mean arterial blood pressure equal stroke volume multiply the heart rate multiply the systemic vascular resistance and the CVP calculation. So here, if you can go to the stroke volume, which is affecting actually with the contractility and after a load. So here the contractility is affecting actually by even from the right, from the left ventricles, and even the right ventricle contractility is very important, because if there is impairment in the right ventricles, like we saw some patients who's COVID-19 basically had RV failure. So if the RV failure is affecting, the stroke volume will be low, and so it will affect also from the right side, stroke volume will be low. So there is not enough blood going to the left side, and it will be stroke volume low. The heart rate, whose the patient has a bradycardia or arrhythmia, tachycardia, they have 3 actually. They can affect the mean arterial blood pressure. And if there is systemic vascular resistance, there is vasodilatation, which we are weak, especially some cytokines storms they have of the COVID-19. So it can be there is vasodilatation, which is actually very bad if it's happened. And we should manage aggressively if we have it. So here the shocks, as we mentioned, inadequate perfusion with or without hypotension, and there is, but actually it should be there is because there is no hypotension, maybe just the mean systolic blood pressure less than 40 from the baseline. But as we mentioned, these 3 numbers you have to keep it in mind. Evidence, clinical evidence of hypoperfusion. In addition to that, there is usually they will complicate it with the kidney, symptomatic with tachypnea, tachycardia, or hypotension, oliguria, after level of consciousness. So here the shock definition: the resistance hypotension despite the fluid resuscitation, and they require vasopressor to maintain MAP more than 65, or and also the serum lactate, it should be more than 2. So there is evidence of hypoperfusion there is the hypotension, and they required vasopressor. If the patient has hypotension and you start vasopressor, not responding to the fluid, but the state is normal, so it's not going with the classic definition of shocks. So here the scenario, and 30 years old. So let us to there is multiple scenario here. Which of these patient they have actually definition of shocks? So just we will put it in the polls, please. You can answer it. So here, which of the following has a definition of shock status, or we have shock status? A 30-year-old male who has blood pressure 80/40, IV fluid given, and his blood pressure respond to the other scenario the same, but they required vasopressor, but lactate is normal. The last one, lactate is high, and then vasopressor. So we have only 8 they respond, 9, 10 now. We need more, please, more answers. Okay, so the majority they are answering the answer C, the 30 years old male who has hypotension and receive IV fluid, not respond, and they required vasopressor, and the lactate is high. So remember again, because there is 2 answers with the option B. The most important, as we mentioned, hypotension, evidence, hypoperfusion, which is not available in option B because the lactate was normal, and required vasopressor. So here, shock by pathophysiology, actually they have capacitancy, inadequate volume, and there is a problem in pump or in dilated circulation. So this is any of them affecting, so it will be there is difficult pathophysiology. So either there is inadequate volume, so just keep it in your mind, CPR, capacitancy, pump, and resistance. So inadequate volume, maybe he's fluid responsive, or there is heart failure. So the pump, there is a problem, cardiac output is low, so you need to inotropic support at that time, or dilated circulation, like the patient who has vasodilatation with types of shock. Here, just we will go fast because of the limit of time, which is but very important. This one, the problems here in the shocks we have. It can be, this is the first tank here, it's normal, but here, if you see there is only the fluid is low, so going with hypovolemia, it can be from inadequate amount of fluid he's taking, his patient diuresis, he's on diarrhea, burn, all these can cause hemorrhagic, also can cause hypovolemia. In distributive, there is vasodilatation, so it can be like an septic shock, anaphylactic shock, all these can cause. In cardiogenic shock, the heart failure, the pump will be, it's not pumping well, but already the tanks is full with the fluids. So here, if the types of shocks, actually we can divide it into main groups, either called distributive shocks, recessive shocks, or you can call it high cardiac output, low cardiac output. So the distributive, what they have low vascular and low systemic vascular resistance. So they are trying to compensate the hypotension by high cardiac output. Like what? Like anaphylactic shock, septic shock, neurogenic shock, and can be also adrenal failure. But in recessive shock, they have hypovolemia, cardiogenic, obstructive. All of these can cause low cardiac output and high systemic vascular resistance. Like the patient has cardiac tamponade, the heart cannot be pumped. So there is low cardiac output. Patient, for example, has obstructive, like has PE. So in the right failure, at the right side of the heart, they are trying to pump, but there is massive PE, so the blood is not going to the left side so there is low stroke volume, so-called obstructive, or the patient has pneumothorax, tension pneumothorax, cannot be, because it will be making there is a pressure in the heart, so cannot go also the blood for the left ventricle. So here just an example, like this patient has one dry peripheries, tachycardia, also pounding pulse. So here the pump is high and there is low vascular resistance and low volume capacitance tank. So what we think here, what's the type? You can write in the chat, please. So is it obstructive? Or just we can say from the beginning, it is recessive or distributive. You can write in the chat, please. So septic or anaphylactic shock, which is called distributive shocks. So distributive shocks, as we mentioned, like septic, anaphylactic, and neurogenic shock. Okay. So the other case, this is the patient who has cold, calming tachycardia, and if you see here, the pump is slow pump, and if you go for the, he has high vascular resistance and he has low volume capacitance tank. So which type it will be? It is distributive or resistive? It is, if it is, so can you write in the chat, please? So hypovolemia, it can be one of the differential, yes. So it's resistive, you can say. It can be hypovolemia, or it can be obstructive. So the other scenario, it's the same. He has cold, calm peripheries, decreased capillary fill, and he has low cardiac output and high vascular resistance. And if you assess the volume status, you will find the tank is full. So where we are? Distributive or resistive? Okay, cardiogenic, so it's resistive. Yes, exactly. So just I will skip this one because, okay. Here just types of shock actually, just to rephrase again, resistive and distributive shocks. As we mentioned, here's the hypovolemia. It can be hemorrhagic, can be fluid loss secondary to diarrhea, vomiting, diuresis. There's also third space, keep it in your mind, interstitial, some patients also they have from high inflammatory marker, they can have it, so just keep it in your mind. Cardiogenic can be vascular, arrhythmia, MI, myocarditis, and the obstructive like massive PE, cardiac tamponade, constructive pericarditis, tension pneumothorax can be, especially with high beep or after the procedures. So just take a home message. Actually, shock is resistance hypotension despite volume resuscitation and requiring vasopressor and to keep the map more than 65 and who has lactate more than 2. Types of shocks, it's resistive, cardiogenic, like cardiogenic, hypovolemic, obstructive, and distributive like septic, anaphylactic, neurogenic, and adrenal. Not all the types of shocks, they are fluid responsiveness, and because the fluid is a drug which it can be very hard for actually if you give it. So early, because if the patient not responding to the initial resuscitate, you have to go for vasopressor. Actually, as the campaign, this is the sepsis campaign, which is just recently published in the COVID-19 management. The first line of vasopressor should be NORAD, as you answered the first question. Noradrenaline is the first line. The second line, you can go for vasopressin. So this is the most important. If there is cardiogenic, it's different. So according to and Dr. Bashir, he will discuss later on all these medication details. Which type, keep in your mind, which types of fluids we need to give resuscitation is balance, crystalloid. It's over than saline fluids. Please, colloids, avoid to use it. It's very expensive and it's the same outcome. So don't lose our resources for unnecessary things, which is we have a lot of trials supporting the balanced crystalloids is more than supporting the colloids. Even in Saudi campaign recommendation, they are preferring to use saline. So let us to follow the guidelines and to save the cost-effective. And thank you, everyone. If you have any question, just you can raise the hand or just write in the chat room.
Thank you, Dr. Ahmed. There is a question in the chat. What type of shock do patients with COVID-19 present with?
Actually, the shocks in COVID-19, it's not common. We find most of them, they have respiratory failure mainly. But some of them, they have developing septic shock in advanced case and cardiogenic shock. So both of them, they can have it. But septic shock usually it will be, if it's happening, it's very poor prognosis, which is not common actually to be. But keep in your mind about cardiogenic shock, especially we are not seeing, there's no study actually about the right heart failure out of literatures about it. But we notice during this era, this month, a lot of them, they have right-sided heart failure. So maybe it's cardiogenic, it can be. And in addition to that, septic shock.
Any other question? I think there is no question, Dr. Ahmed.
Okay,
Thank you very much. And we will start another lecture. Okay, good evening again for those who joined late. So I am Dr. Gültekin Bekirova. Topic which I will present is arterial blood gases. I think there is no doubt that APG is most frequently requested investigation in ICU, and equally it's very important investigations. And knowledge of it should be, it's very important for doctors, for nurses, and respiratory therapists. Especially it's important in ICU environment. Sampling of ABG performed under aseptic condition from radial, brachial, or femoral arteries. Mainly we are using the radial artery for sampling. And the samples should be immediately sent to lab or placed in ABG machine to exclude the errors. There are indications and contraindications for ABG sampling as well as A-line placement. So indications include guide the adjustment of ventilator, recognition of metabolic disorders, and respiratory disorders as oxygenation and ventilation disorders. And there are as well contraindications for ABG, includes absolute and relative contraindications, as abnormal Allen test, local infection or distorted anatomy, presence of AV fistulas, known or suspected severe peripheral vascular disease. And there is also relative contraindications as severe coagulopathy, anticoagulation therapy, and thrombolytic agent use. Allen test used to detect the patency of ulnar artery. And if ulnar artery is patent, so radial artery can be utilized for A-line placement and ABG sampling. To know the pathology, we have to know the normal values. So on the screen, you can see the normal ABG values, and every physician should memorize these values to recognize the abnormality. We can get in other informations from ABG sample as hemoglobin, sodium, potassium, lactic acid, carbon monoxide, and methemoglobin levels. I will not go deep to physiology of pH regulation. Just we have to just for revision. There is always lung and kidney standing for each other for pH regulation and for compensation in the form through the release of CO2 and excretion of the bicarbonate, as well as production of bicarbonate. So these are two organ systems which are working for pH regulation. And this slide represents the normal value as well as extremes of pH, blood pH, which lead to this. One of the important formula in interpretation of ABG is a Henderson-Hasselbalch equation. It's used to recognize the consistency of the ABG. So it's a relation between hydrogen ion concentration and CO2 and bicarbonate in the blood. So you can see the upper formula, which we may utilize in ABG interpretation. Hydrogen ion and its relation to partial pressure of carbon dioxide as well as bicarbonate. This table representing the relation between hydrogen ion concentration and pH. If you can see, more hydrogen ion, a more acidotic state, less hydrogen ion, more alkalotic state. Coming to interpretation of the ABG, so there are 6 simple steps to read how to read the ABG. Step number 1 is this acidemia or alkalemia. Step number 2 is the primary disturbance, respiratory or metabolic. Step number 3 is the respiratory problem, acute or chronic. Or 4, oxygenation disorders, we can see the hyperoxemia and hypoxemia. Hyperoxemia almost always iatrogenic, and by simple titration of the oxygen supplementation, you may get to normal values. For hypoxemia, there are 2 types of hypoxemia with low partial pressure of oxygen and normal partial pressure of oxygen. So low partial pressure of oxygen and hypoxemia we can meet in following pathologies as diffusion problem, vacuum mismatch, hyperventilation, low oxygen saturation in ambient air, right to left shunting. For we can see also hypoxemia with normal partial pressure of oxygen, where you can see the normal PO2 level, but sometimes the tissues are getting hypoxic. In following pathologies as anemia, carbon monoxide, methemoglobin, cyanide poisoning, as well as hypoperfusion states. For ventilation disorders, again, there can be respiratory acidemia and respiratory alkalemia. For respiratory acidemia,
Dr. Gultekin,
yes?
the presentation, can you share it? Because it's not showing, there's no slide.
Just a moment, please. Just a moment, please. Just a moment. What about now, Dr. Ahmed?
Still not yet.
Still not yet. Just a moment, please. What about now? You can see now the slides?
No. You can just click again down from the share and select the PowerPoint.
Still not yet?
Not yet.
So I'm apologizing for technical problem. We will try to share again. What about now, Dr. Ahmed?
Yes, it's okay now. Just make it full screen, please.
We can see now? You can see now, Dr. Ahmed?
Yes. Just make it full screen, please.
Okay. What about now?
It's okay.
Is it okay?
Yes, okay. Can you proceed, please?
Okay. So I am sharing the slide of respiratory disorders, and respiratory disorders can be oxygenation and ventilation disorders. For oxygenation disorders, as we discussed previously, there is hyperoxemia and hypoxemia state. Hyperoxemia state, it's almost always iatrogenic, and by titration of the oxygen, we can improve this situation. For hypoxemia, there is, you can see Dr. Ahmed? Dr. Ahmed? Dr. Ahmed?
Yes, doctor.
We can see the screen?
Yeah, we can see.
Yeah, okay, so I will continue. And for ventilation disorders, there is respiratory acidemia as well as respiratory alkalemia. Respiratory acidemia classified to acute and chronic. Causes for precipitating acute respiratory acidemia, including traumatic brain injury, anesthesia, side effect, disorders as Guillain-Barré syndrome and multiple sclerosis. Well-known chronic acidemic respiratory acidemia, it's a COPD case. For alkalemia, respiratory alkalemia, the pathology which may lead to it, it's hyperventilation disorders, pregnancy, respiratory stimulant as caffeine, for example, and liver failure. So we will discuss case study. The patient presented with a one-day history of productive cough, fever, and dyspnea, ABG with pH 7.55, PCO2 of 30, PO2 of 63, and bicarbonate 22. So just comment on this ABG, which type of disorder represented by this ABG. You can write in the chat. Okay, so most of the participants choose the third answer, yes. It's a respiratory alkalemia and hypoxemia. Okay. Coming to acid-base disturbances, acid-base disturbances can be primary and mixed disorders. Primary disturbance including isolated respiratory acidemia, respiratory alkalemia, or metabolic acidemia and metabolic alkalemia. Mixed disorders, this combination, possible combination, all of them apart from respiratory acidemia and respiratory alkalemia. In one ABG, we will not see at same time presence of these two primary disorders. It's a picture which represents the clinical symptoms and sign of patient with metabolic acidosis and metabolic alkalosis. It's an unspecific presentation with a headache, hypotension, hyperkalemia, with a warm flushed skin, etc. And this is a presentation of metabolic alkalosis. So next important slide, it's a simple algorithm how to approach the patient with a metabolic disorder. So first of all, check the pH. Is this acidemia or alkalemia? If pH less than 7.35, it's acidemia. If more than 7.45, it's alkalemia. For acidemia, go to recognition of type of acidemia. Is it metabolic or respiratory? If it's respiratory, so CO2 will be more than 45 millimeter mercury. And again, we have to distinguish, is it acute or chronic respiratory acidemia? If it's acute respiratory acidemia, so possible causes as TBI, anesthesia, Guillain-Barré, and multiple sclerosis cases or myasthenia. For chronic respiratory acidosis, so COPD is the classic cause for chronic respiratory acidemia. Coming to more complicated metabolic acidemia. If there is bicarbonate in the ABG less than 22, look for anion gap. Anion gap, as you can see from this formula, from serum sodium, you have to subtract the chloride and bicarbonate. Normal level of anion gap, it's 12 plus minus 4. So around 8 to 16 is a normal anion gap. And if it's the number more than 16, so we have the ABG with high anion gap metabolic acidosis. In this case, we have to check the ratio between gap of anion gap and gap of bicarbonate. What is the gap of anion gap? It's a difference between the calculated anion gap and normal level of anion gap. Similarly, the gap of the bicarbonate, it's different between normal bicarbonate level as well as calculated bicarbonate level. If this ratio between 1 and 2, patient having only simple high anion gap metabolic acidosis. If this ratio less than 1, there is combined mixed disorders, high anion gap and normal anion gap metabolic acidosis. If this ratio more than 2, it's combination of high anion gap metabolic acidosis with metabolic alkalosis. Also important in metabolic state to check the osmolar gap. What is the osmolar gap? It's a difference between calculated and measured osmolar gap. If it's more than 10, so there is, you can think about such a pathologies as a toxic alcohol intoxication, as methanol, etc. Normal level of osmolar gap is less than 10. Another important point for metabolic acidemia is to calculate albumin and correct the deficit of albumin to anion gap, because as we know, albumin is a weak acid, and deficit of albumin will lead to false reading of false calculation of the anion gap. It will be more so anion gap will be less than actual anion gap. So we have to correct for each 1 gram per deciliter loss in albumin. We have to increase the anion gap by 1 to 2.5 up to 3 millimole. We have to add to anion gap. Causes of high anion gap represented in the red box. High anion gap metabolic acidosis, you can memorize, and mud piles, as mud piles. So methanol, uremia decay, paraldehyde, and in other pathologies may lead to high anion gap metabolic acidosis. Coming to normal anion gap metabolic acidosis, causes for this is you can memorize as fused cars, and you can read it in the box, red box below. In case of normal anion gap metabolic acidosis, we have to calculate the urinary anion gap. So what is the urinary anion gap? Simply from urine analysis, we have to get the sodium level, potassium, and chloride level. So sodium plus potassium minus chloride, it will, if the gap is positive, so possible cause of normal anion gap metabolic acidosis is renal. If its anion gap is negative, so cause for normal anion gap is non-renal. So we finished with the acidemia, and we are shifting to alkalemia box. If bicarbonate more than 26 millimole, in some reference you can find 28 millimole. So patient having the metabolic alkalemia disorders. For this reason, we have to check the urinary chloride. If urinary chloride less than 10 millimole, so patient probably have the chloride responsive metabolic alkalemia. For chloride responsive metabolic alkalemia, just simply we have to replace with the normal saline, and it will be corrected. In case if the urinary chloride more than 10 millimole, so patient might have the chloride resistant metabolic alkalemia, which will not be corrected by simple supplementation with normal saline. So as a reason for this, mineralocorticoid excess, adrenocorticotropic hormone excess, and other disorders. Coming to respiratory alkalemia, in this case, the PaCO2 will be less than 35 millimeter mercury, and cause for this hyperventilation, pregnancy, liver failure, and respiratory stimulants. I will skip these slides because all of these slides already I discussed in previous algorithm. Okay, so I will skip them, all of them, and we will move to second case study. An otherwise healthy 50 years old male sustains acute upper airway obstruction during the induction anesthesia, then he vomited and aspirated. ET tube was placed and ABG were as follows: pH 7.10, PaCO2 of 70, bicarb of 15, and PaO2 of 15. Please write your opinion about this, comment on this ABG. What is the disorders you can find out from this ABG reading? You can write in the chat. So most of the participants writing number 3, answer number 3, yes, it's acute respiratory and metabolic acidemia and hypoxemia. Yes. We are moving to next slide. Okay. So case number 3, 56 years old man with COPD and resting PaCO2 of 70 millimeter mercury sustains an acute myocardial infarction. His blood pressure is 85 over 58 millimeter mercury, and he's diaphoretic and having cold and clammy skin. His ABG with the following reading: pH of 7.1, PaCO2 of 70, PaO2 of 73, and bicarbonate of 21. So comment on this ABG and write in the chat, please. So answers are mixed. Actually, the correct answer is chronic respiratory and chronic respiratory acidemia, as well as acute metabolic acidemia. Why chronic? Because we mentioned in the case that this is a case of chronic COPD with resting CO2 of 70. So we will consider it as a chronic respiratory acidemia. And we will move to next slide. Okay. Here is the rules which we have to memorize as for a bedside interpretation of ABG. So it's a rule for memorizing how to interpret the ABG on the patient bedside. So metabolic disorders, compensatory rules. In case of metabolic acidemia, so PaCO2 will decrease by 1 to 1.5 times in bicarbonate decrease, or the last two digits in the pH will be equal to PaCO2. So in this case, we can say that metabolic acidemia is compensated by respiratory efforts of the patient. In case of metabolic alkalemia, there will be compensation by this way, that PaCO2 will be increased by 0.25 to 1 times the increase in bicarbonate. For in other rules for ventilation disorders, there are also compensation rule, which we should memorize. For respiratory acidemia, so acute rise in PaCO2 to 10 millimeter mercury will lead to acute rise in bicarbonate 1 millimole per liter. In chronic cases, this compensation will be 4 millimole rise in the bicarbonate to each 10 millimeter mercury rise in PaCO2. For respiratory alkalemia, in acute state, but if the PaCO2 for each 10 millimeter of PaCO2 drop, bicarbonate will drop to 1 to 3 millimole per liter. Similarly, for chronic state, this compensation will be more obvious. So for each 10 millimeter mercury drop in PaCO2, bicarb will be dropped to 2 to 5 millimole per liter. This is just a simple way how to bedside interpret the ABG. It's a tic-tac-toe method. As you know, this tic-tac-toe method is an indoor kids game. So just simply you will make the 6 boxes with the normal, acidic, and basic boxes. And let us try one example. So we have the ABG with pH 7.25, PaCO2 of 32, and bicarbonate of 18. So pH is showing the acidotic state, so we are placing in the acidotic box. PaCO2 32, we are placing in the basic box, and bicarbonate is 18, we are placing again in acidotic box. So we have here metabolic acidosis. Now coming to how to recognize the disorder, compensated or not compensated. Those are the rules how to determine the compensation. So if the pH is normal and PaCO2 and bicarb are both abnormal, so this is compensated state. If pH is abnormal, PaCO2 and bicarb are both abnormal, it's a partially compensated state. If the pH is abnormal and PaCO2 or bicarb is abnormal or PaCO2 or bicarb, so it's the uncompensated state. So let us try now this example. pH 7.43, PaCO2 of 30, and bicarb of 21. pH is normal. PaCO2 is low, so we are placing in basic box, and bicarbonate we are placing in acidic box. So this is normal pH with both abnormal PaCO2 and bicarbonate. So it's compensated ABG. And I am coming to last slides of my presentation. Those are multiple formulas which can be utilized for ABG reading, and it's really nearly impossible to memorize all of them. But most important formula is upper formula. It's a compensation. It's called the winter formula, compensation of metabolic acidosis by respiratory system. So this formula should be memorized and should be utilized bedside for ABG interpretations. Again, coming to 6 simple steps reading of ABG. So step number 1, is this acidemia or alkalemia? Step number 2, is the primary disturbance respiratory or metabolic? Step number 3, is the respiratory problem acute or chronic? Step number 4, for metabolic acidemia, what is anion gap? Then step number 5, are there any other process in the anion gap acidemia? And last step, is the respiratory compensation adequate? It means winter formula is the step number 6, which you have to memorize and utilize for bedside ABG interpretation. Thank you very much. And if you have any questions, please welcome, and you can write in the chat or raise your hand. Okay, anyone have a question? Okay, seems there is no questions, so we will move to next lecture. So next lecture will be presented by ICU senior consultant, Dr. Basim. He will present the basics of mechanical ventilation in COVID-19. It's very important part of and very important part of ICU work, knowledge of ventilator management. And Dr. Basim, you're welcome. You can start your presentation and share your presentation, please. Dr. Ahmed? Dr. Ahmed, can you unmute Dr. Basim, please? Dr. Ahmed?
السلام عليكم.
Dr. Basim, can you share your presentation?
Sharing, Dr. Ahmed, please. I'm trying to share my presentation. Assalamu alaikum, everyone. Sorry for the delay. I'll be speaking on, they called it the basics, but I like to call it the essentials of mechanical ventilation. I'm calling it essentials because it is not even the basics. I have cut short my speech to try to tailor it down to your needs as non-intensivists. So this is just a glance to for you to be aware of what is happening around you while you're spending some time in ICU. So we are late already. I will start. I will make it short, as I said. And most importantly to me, I would like to introduce two concepts that if you understand, I think the details will not matter. And I will start with a simple question. This is the question: what are the defining or essential components of mechanical ventilation in your opinion? All these are common associations with mechanical ventilation, but which one is essential, which means that you cannot remove out of mechanical ventilation? Oxygen, pressure, airway, or sedation? Tell me what you think on the chat, please. B, C, B. Okay, there's a strong competition between B and C here. I have a D, sedation. You can choose all of the above or as many as you wish. C. Okay. No one's choosing A. Anyone more? Okay. Let's think of it. Sedation. Can you ventilate a patient without sedation? Yes, if they're highly cooperative on invasive mechanical ventilation, but more commonly on non-invasive mechanical ventilation, you would ventilate a patient without any sedation. Can you ventilate a patient without definitive airway, endotracheal tube or tracheostomy tube? Yes, again, on non-invasive mechanical ventilation. And obviously, none of you chose A, which is oxygen, because if the patient does not have any problem with oxygenation, then you would not necessarily add any oxygen above room air. So the essential component of mechanical ventilation, the only essential component of mechanical ventilation is pressure. So mechanical ventilation essentially includes pumping air under pressure. Now, if you remember the physiology, the lungs, the alveoli are always under negative pressure. During inspiration, you inhale the air, atmospheric air, under negative pressure, and you allow it passively under zero pressure during expiration. So mechanical ventilation goes directly opposite to the norm, opposite to physiology. And hence, it has an inherent harm to the alveoli, a harm that cannot be removed out of mechanical ventilation. It can be minimized, but it cannot be removed. So this is one concept to remember. Whenever you are applying mechanical ventilation, you are essentially causing some harm. It is necessary, but remember, it is harm. It applies to mostly any medical intervention, but this is very important to understand. The other concept is that mechanical ventilation is just a support. It's not a treatment. It does not treat respiratory failure. Respiratory failure is always secondary to something else. Respiratory failure is like fever. So it is secondary to pneumonia, secondary to pulmonary edema, secondary to pulmonary embolism, secondary to heart failure. So the definitive management should target the pathology while bridging this onto mechanical ventilation to avoid the patient dying while the definitive management is working. From these two concepts, we understand that mechanical ventilation does not do a dose-dependent benefit to the patient. It is not the more the better. You are not targeting a normal ABG. It will not benefit the patient in anything. So it's just to keep the patient alive. And knowing that it is inherently harmful, so you need always to keep mechanical ventilation minimal. Minimal in which aspects? In every aspect. In application in the first place, which means if the patient does not necessarily need mechanical ventilation, he shouldn't be on mechanical ventilation. Minimal in invasiveness. If a patient is suitable to be ventilated or non-invasive mechanical ventilation, he should not be hooked to invasive mechanical ventilation. Minimal in pressure, minimal in oxygen, minimal in volume, and minimal, most importantly, maybe in duration. So whenever the patient is ready to be freed from mechanical ventilation, he should not wait more. So understanding this is very important so that you know what we exactly are doing with mechanical ventilation. The second thing is just a glance about the relationship between volume and pressure in mechanical ventilation. This diagram represents the alveoli and airways. The alveoli are represented in the circle and the airways are represented in the tube. The airways, remember, during mechanical ventilation do not only include the bronchi, bronchioles, and trachea, but also the endotracheal tube or tracheostomy tube and the ventilator tubings. And the alveoli is the collection of the alveoli, not only a single alveoli. So looking at this diagram, you will understand that there are two different types of pressures generated during mechanical ventilation. One to distend the alveoli against its or their tendency to collapse, and another to overcome the resistance in the tubes. Now, this second pressure is not, or passing the tube is just the way. The goal is to reach the alveoli and distend them, but you have to go through the tubes. Any tube physically applies resistance, and the pressure generated is the relationship between the flow, which is the amount of air you pump in a time unit, in a second, multiplied by the resistance. The resistance of any tube is directly proportionate to its length. The longer the tube, the higher the resistance, and inversely proportionate to its diameter. The bigger, the wider the tube, the less the resistance it applies. The narrower the tube, the higher the resistance it applies. So we understand that if you pump the air so quickly with a high flow, and if the tube are applying high resistance, then you will generate, or you will have to generate higher pressure to overcome this kind of resistance. Now that once you have arrived or reached to the alveoli, there's another pressure needed to distend these alveoli. And this pressure is directly proportionate to the volume you want to distend the alveoli with, and it is indirectly or inversely proportionate to the compliance. Compliance is the opposite of the elastance. Compliance is good, elastance is bad. So compliance is the ability of the alveoli to accommodate higher volume without getting higher pressure. So the better the patient's compliance, his lungs compliance, then the lower the pressure you need to generate for a given volume. The third kind of pressure that together with these two contributes to the peak airway pressure is the PEEP, which is the positive end expiratory pressure. This is the residual pressure we keep in the lungs at the minimal pressure point at the end of expiration. So during this era of modern mechanical ventilation, we stopped allowing all air out of the lung during expiration. We keep some air inside to keep the alveoli open. So this is called, this volume we keep generates pressure. This pressure is the positive end expiratory pressure. So the PEEP plus the volume divided by the compliance, plus the flow multiplied by the resistance, all together will compose the peak airway pressure. Now, the second slide illustrates an important thing, which is what happens when the flow stops. When you have pumped all the tidal volume inside the alveoli and stop the flow, you didn't allow it to go out during expiration. So you stop the cycle at the end of inspiration. Now there's no flow, and hence the whole flow multiplied by resistance component is eliminated. This leaves us only with two components, which is the component needed to distend the alveoli and the PEEP. This pressure is very important. We call it the plateau pressure or the alveolar pressure. It is more important to us than the peak airway pressure because it is proven, evidence-based to correlate with the patient's outcome. So the higher the plateau pressure, the worse for the patient's outcome. So this is a major goal during mechanical ventilation, to keep the plateau pressure within the limit we have found to be safe. With this introduction, we can go now more to the details. Indications of mechanical ventilation are obvious. At least the two first categories are obvious to you, which is respiratory failure, whether type 1, like in pneumonia, cardiogenic pulmonary edema, and anything like you've just heard the ABG lecture from Dr. Gultakin, or type 2 like COPD exacerbation, acute severe asthma, Guillain-Barré, and these kind of pathologies. Another category of indications is protection of airway. You need to protect airway whenever it is compromised, like in trauma, coma, anesthesia, inhalational injury, corrosive swallowing. So at this point, your goal is not actually to ventilate the patient, it is to protect the airway through endotracheal tube. And mechanical ventilation comes as an essential association with intubation then. So this is the second very common category of indications needed in mechanical ventilation. The last and very important, sometimes overlooked, is trying to balance oxygen delivery versus oxygen consumption. This happens during shock states. Shock state, by definition, you've just heard Dr. Kuhail's lecture, is the imbalance between the oxygen delivery and the oxygen consumption, where oxygen delivery falls and oxygen consumption is the same or increased. Applying mechanical ventilation would obviously improve the oxygen delivery for obvious reasons, but it also decreases the oxygen consumption. Decreases oxygen consumption through mainly two mechanisms. It alleviates the work of breathing needed by the patient now that the mechanical ventilation is in charge of the job. So the patient does not need to pay energy or oxygen to breathe. And secondly, it allows us to fully sedate and maybe paralyze the patient. So this also alleviates not only the respiratory muscles, but all the voluntary muscles. So this way you can decrease the oxygen consumption and increase or improve the oxygen delivery. So these are the main three indications under which falls many pathologies, as you understand. Mechanical ventilation, like any medical intervention, when you are starting it, you need to set your goals. And obviously, the main goals of mechanical ventilation is controlling the ABG, but as we said, you do not necessarily want a normal ABG, but you want an acceptable ABG in terms of oxygenation. And oxygenation you can manipulate through mechanical ventilation by increasing the pressure or increasing the oxygen, FI2, the oxygen concentration. Obviously, we said we want to decrease both of them. So you manipulate them in a way to keep the other targets in goals. And the other goal is controlling CO2, and CO2 can be controlled by what we call the minute ventilation. Minute ventilation is the total amount of air inspired by the patient in a full minute. So it is the tidal volume, which is the volume per breath, multiplied by the respiratory rate. So increasing the tidal volume or increasing the rate, any of them would increase the minute ventilation and hence decrease the CO2 and improve the pH. These are the two main goals, but while doing this, you need to ensure the patient's comfort, and this can be achieved by careful selection of the mode and by the wise usage of sedation and or analgesia. And while doing this, you need to always keep in mind that minimizing harm is a very important goal in mechanical ventilation, because we said it is harmful, so you want to minimize harm. These are the goals. If a patient has respiratory failure, for example, and you need to ventilate him, the first question is whether he is a candidate for non-invasive mechanical ventilation, or you will go directly to invasive mechanical ventilation. As we said, invasiveness is one thing you want to minimize, and non-invasive is always preferable if it is suitable. The problem with non-invasive is that it is not suitable for most critically ill patients, and we will in a minute show why. The very famous indications of non-invasive mechanical ventilation, and where substantial evidence is available, are three: cardiogenic pulmonary edema, COPD exacerbation, and obstructive sleep apnea. However, non-invasive mechanical ventilation is being used for many more indications, and this is based on the absence of contraindications. This makes contraindications, in my opinion, to non-invasive mechanical ventilation more important than indications. So I would say simply, with no accuracy, that whenever a patient is not contraindicated to be on non-invasive mechanical ventilation, it's worth a trial on non-invasive, but a careful trial, and we will come to that. So contraindications to non-invasive mechanical ventilation, in contrast to indications, are multiple. These are just some examples. So if a patient is not protecting the airway, this is a contraindication. A patient who is not fully comfortable or cooperative on non-invasive, any patient who has significant hemodynamic instability, significant metabolic derangements like acidosis or uremia or whatever, a patient who has excessive secretions that he cannot manage on his own, and a patient who has facial trauma or burn. These are all contraindications to non-invasive mechanical ventilation. Complications of mechanical ventilation are also multiple, and also these are but just some examples. Secondly, to the pressure on the interface, it can cause pressure ulcers. Some people develop claustrophobia. Abdominal distension sometimes is inevitable. Aspiration is a possibility, and both distension and aspiration will result in impaired nutrition. But the most important complication of non-invasive mechanical ventilation in practice, the one that we should always keep an eye on, is delaying intubation while it is indicated. This is the most harmful production or product of non-invasive mechanical ventilation. Applying non-invasive mechanical ventilation to a patient will almost always make him look better. So if you are not keeping a very careful eye on the patient, you may miss the opportunity to intubate him when he needed it. And delaying intubation is well known to cause adverse events on the patient's outcome. So this is for non-invasive mechanical ventilation. So if a patient is suitable on non-invasive mechanical ventilation, in short, he can get a trial. The trial should not be more than 2 hours, very initially, very well monitored, and with low threshold for intubation. Should you feel that the patient is not benefiting, is not obviously improving on non-invasive mechanical ventilation, then do not delay intubation. Now we'll go to invasive mechanical ventilation, and I will try to go initially very quickly through the basic modes of mechanical ventilation. There are a multitude of new modes that you will not need to know of now, but three are the basic modes of mechanical ventilation. These are called volume controlled or volume cycled, pressure controlled or time cycled, and pressure support or flow cycle. The word cycle means the way inspiration ends, how the ventilator ends inspiration and cycles or switches or changes to expiration. So in volume control mode, the ventilator switches to expiration when a target volume is reached. So in this mode, it is an assist control mode, which means that you get to dictate all the aspects of a breath, the volume, how much the volume is, how much the time is, how much the flow is, everything. You get to dictate this, but your goal is volume. So when you target a volume, the ventilator will push air this much volume you have required, and the pressure will be just a result of the volume you have decided. You cannot control both volume and pressure together. So controlling volume will make the pressure a consequence. You need to monitor the volume, try to limit the pressure, try to limit it to decrease the harm, but you cannot control the pressure in volume control mode. As we said, all breaths are mandatory, which means the patient can only ask for a breath, which we call assisted breath, but then the breath is always dictated by the ventilator. How much the volume, how much the time. Another popular mode and basic mode of assist control, which means all the breaths are mandatory also, is the time cycle. Time cycle means that after a given time that you get to decide when you are setting your ventilator, after a given time under a certain pressure you also set, then the inspiration ends and expiration begins. This is why we call it time cycle, because it ends after a given time. We call it also pressure control because here the target is pressure, not volume. So you inflate the alveoli to a certain pressure that you have chosen during your settings. Now, choosing pressure will make the volume a consequence. It is the opposite. Again, you cannot control both. So on pressure control, you need to keep an eye on volume, but you cannot control it. Both are assist controlled modes that are suitable for starting mechanical ventilation and for sicker patients. There is no evidence-based difference between pressure control and volume control in terms of outcomes. So the difference comes from individuals and institutional preference and protocols and experience. So you can start a patient on invasive mechanical ventilation, whether on pressure control or on volume control. The third popular and basic mode of mechanical ventilation is flow cycle. Flow cycle means that the inspiration ends when flow, the inspiratory flow drops to a certain value that also you have chosen during your set. This is called pressure support, and the word support denotes that this is not mandatory breath. It is a spontaneous mode where the patient is actually breathing spontaneously, but it is supported by the ventilator. The patient decides when to start the breath, when to end the breath, and how long the breath is, and how much the volume he will take. He will need to pay more effort to get more volume, but it is his decision, not the ventilators. So this is why this is the most popular weaning mode. It's a weaning mode. You cannot start mechanical ventilation on pressure support. You will always start it on whether pressure control or volume control. When you're weaning, then the most popular weaning mode is pressure support. This is a quick glance on the modes of mechanical ventilation. So if we have said this, now you are starting invasive mechanical ventilation. How will you initially set your ventilator? As we said, you have to choose assist control, whether volume control or pressure control, where all the breaths are mandatory, dictated by the ventilator. Oxygen, you would always start on 100%, then you can decrease that based on the patient's ABG and pulse oximetry. PEEP, the positive and expiratory pressure, usually we would start on 5 to 8 and then adjust it based on the patient's needs. And then volume. We assume you have started on volume control. This is the commonest mode to be used in our institution in KSMC. So volume differs whether the patient has ARDS or does not have ARDS. In ARDS, it is evidence-based that lower volumes ends in better patient's outcome. So if the patient has ARDS, you would start with 4 to 6 milliliters per kg of ideal body weight. And in non-ARDS patients, you can start with higher pressures, 8 to 10 milliliters per kg of ideal body weight, usually 8. So this is the volume. As we said, the CO2 is controlled by the minute ventilation, which is the tidal volume multiplied by the respiratory rate. So the respiratory rate, you will set it after you have set the volume, because if you have chosen a higher volume, then you will need a lower rate. And if you have chosen a lower tidal volume, then you will need to apply initially a higher respiratory rate. After you've set this, you will watch the patient maybe for 15 or 30 minutes and then take an ABG. What do you monitor? Obviously, the saturation, the pressures on the ventilator, the development of something called the auto PEEP. Most importantly, the patient clinically, and eventually the ABG. And then you adjust according to the findings you see. These are the initial settings. After you have initiated mechanical ventilation and after you have adjusted the ventilator to the patient's specific needs, you watch. Remember that we said mechanical ventilation should always be coupled with the definitive management that is targeting the patient's pathology. As the patient improves, you should be always thinking of weaning, because we said we want to minimize the duration of mechanical ventilation as much as possible. So weaning goes into 3 steps. The first step is making sure that the initial reason for which the patient is hooked to mechanical ventilation has improved. This, as obvious as it is frequently overlooked by non-experienced operators. So you cannot jump into a weaning trial just because the ABG is good or the oxygen requirement is low or because the patient is conscious. If you have started mechanical ventilation in the first place because of severe pneumonia, for example, then pneumonia has to have proven to be improving, not necessarily resolved altogether, but improving at least in terms of X-ray, fever, shock, secretions, whatever. So this is just an example. So the cause for which you have started mechanical ventilation has to have improved first before you can even think of weaning. If this has happened, then there are a lot of conditions to meet before actually commencing the process of weaning. So you need to find out that there are no contraindications for weaning. So even if the initial cause has improved, there may be contraindications to weaning. If the patient needs high settings on mechanical ventilation, if he has significant hemodynamic instability, severe metabolic derangements, inability, if the patient is unable to protect his airway, like he's comatose, for example, if the X-ray is worsening, if he's highly febrile, if he has severe metabolic acidosis, and if he's unable to clear secretions, these are all contraindications to weaning. So an example, if the patient was initially ventilated to protect airway because he was unconscious, for example, so he's intubated and ventilated for this reason. After some time, the patient regained consciousness and hence step 1 is fulfilled. So looking at the contraindications, maybe during this period between starting mechanical ventilation and the patient waking up, he developed, for example, ventilator-associated pneumonia, which will make the X-ray worse, the settings of mechanical ventilation higher, and maybe hemodynamic instability. So although the initial cause has improved, but you cannot start weaning now. These are contraindications to mechanical ventilation. You can apply the same concept to whatever indication of mechanical ventilation. But if there's no contraindication for weaning and the initial cause has improved, now you can proceed to step 3. Step 3 is what we call the spontaneous breathing trial. So you allow the patient to start breathing on his own spontaneously and watch him. If he does well in this during this trial, that typically should take between half an hour and 2 hours. If he does well, and I'll tell you in a minute what does well mean, then you can extubate the patient and allow him to really breathe spontaneously. As we said, the most popular mode of spontaneous breathing trials is pressure support. We usually couple it with a constant PEEP, so we call it CPAP plus pressure support. During this period, the patient is breathing spontaneously, but still on mechanical ventilation and supported by mechanical ventilation. This mode allows you to keep the endotracheal tube in and to monitor the patient well, monitor the volume he's taking, monitor him clinically, monitor his ABG, monitor his rate. And if all signs point towards the patient is able to breathe adequately on his own, then this is the time to take out the endotracheal tube and free the patient totally from mechanical ventilation. So during the spontaneous breathing trial, you monitor the vital signs, the signs of respiratory distress, his pattern of breathing, something called the rapid shallow breathing index, which has to do with the patient's tidal volume and respiratory rate. You take an ABG. If any deterioration happens during the spontaneous breathing trial, then you go back to assist control, which is volume or pressure control, the mode he was on before this trial. But if it is successful, then you can proceed for extubation now. The last section is the complications of mechanical ventilation. As we said, mechanical ventilation always carries some harm. All you can do is try to minimize it. So there are obviously complications that are related to airway. Also, there are complications that are related to sedation. These are not, strictly speaking, the complications of mechanical ventilation, but most of the time you cannot, these are common associations. But strictly speaking, the complications of the mechanical ventilation per se, something we call ventilator-induced lung injury, VILI. These can be barotrauma, voluotrauma, atelectotrauma, or biotrauma. Barotrauma obviously means harm secondary to pressure, like pneumothorax, for example. Voluotrauma means harm secondary to high volumes. Atelectotrauma means harm caused to the lungs by the cyclical opening and closure of the alveoli during inspiration and expiration. And biotrauma means the local inflammation that happens to the lungs secondary to mechanical ventilation itself and causing harm, a picture of ARDS itself. So VILI is one category of complications. Infection, ventilator-associated pneumonia or ventilator-associated tracheobronchitis is a very common and has a dreadful outcome for the patient. So also it is very common during mechanical ventilation. There are bundles that target decreasing the rates of ventilator-associated pneumonia. However, you cannot totally eliminate it. Diaphragmatic atrophy is very common. It is a relatively new concept in mechanical ventilation, but it is now found to have profound effects on the patient's outcome, and that it is happening very early on in mechanical ventilation. When the patient relies on mechanical ventilation, this inevitably causes some atrophy to the diaphragm and consequently makes it difficult to wean the patient. So these are some of the complications of mechanical ventilation. I think this concludes my speech, and your questions are welcome.
Thank you very much, Dr. Basim, for very interesting lecture. If anyone have questions, please raise your hand or write in the chat. Seems there is no questions, Dr. Basim. Thanks again. Thanks again.
Means only that people have understood everything or didn't understand anything. So I hope it is the first.
Yes,
Thanks a lot
of
for
course.
having me today. Good luck.
Thanks, Dr. Basim. So next lecture will be presented by Dr. Bashir. He's our clinical pharmacologist. He has a good experience in ICU. He will present a topic related to his specialty, pharmacology of COVID-19. All of us know that there are many controversies in COVID-19 management, including medicamentouse management. So it's very interesting and very important topic with so many controversies. Dr. Bashir, please, you're welcome. You can share your slide, please. Thank you very much.
Thank you, Dr. Agul Takim. Thank you very much. Thank you for having me today. Now I am sharing this. Okay. Is it okay? Can you see the slide?
We can see Dr. Bashir.
Yes. Okay. Thank you very much. Now I will try to make it or to start quickly with this topic. I will talk about the drugs we are using with COVID-19 viruses and this epidemic issue. Unfortunately, we know that there is no definite management. We don't have any definite management for COVID-19 till now. Many drugs we are using, even in vitro or with the humans only, also, even some of them unapproved for infectious indication, but we are using and trying to fight this virus. I will try to go through most of those medications, and I will tell you regarding about our cluster 1 protocol medications at the end. A small introduction regarding the virus, COVID-19 virus. It's attaching to the receptor binding gene region, that of same for SARS coronavirus. And the virus has been shown to use the same receptor, the angiotensin converting enzyme 2, for cell entry. And its RNA is closest to the RNA came from bat coronaviruses, so they thought that the origin from bats. Regarding this angiotensin converting enzyme 2, many questions regarding the use of ACE inhibitors. Of course, there is no rule for ACE inhibitors to be used for COVID-19, but we know with those patients, hypertensive patients, they are using ACE inhibitors or ARBs, they will have overexpression of those receptors. So we suggest and we think that they should and they have to keep going with and keep taking those medications to block those receptors, because you are giving the viruses much higher number of receptors. So regarding ACE inhibitors and ARBs, they are not a treatment for COVID-19, but they may reduce the cell entry because they are blocking the receptors the virus is using. Regarding this virus, it's positive sense RNA virus and enveloped virus. So unfortunately, it's very easy to attach and replicate, but not easy to treat. Regarding the illness, it's not exclusive for elderly or advanced age people, of course. There's some young people, they will have this complication, especially respiratory complications and septic shock with this coronavirus infection. But we know that with advanced age and more comorbidities, maybe the ratio will be higher, or the percentage, the prevalence will be higher of acute respiratory syndromes. Comorbidities also can affect the use of medications. Many comorbidities will limit our drugs functions and limit us to use those drugs. So sometimes comorbidity is not related to coronavirus, but we cannot use some medications. Like those with acute kidney failure, we cannot use remdesivir, for example, the suggested drug by the FDA to be used for this one. So some comorbidities will make an addition challenge to the treatment. Some will ask why we do not make a drug or find a treatment. In general, FDA will take almost 12 years to approve any medication. Of course, 1 to 2 years at least to produce or to make this drug, but the approval will take long time. But in this situation, we have some exceptions, like that we are calling fast track approval. We can use unapproved medical countermeasures or unapproved indication for some drugs. We are using them with conditional FDA approval called fast track approval. So it's not easy to have approved FDA drug for this indication. Even with some positive trials, we cannot get a very good or a high approved indication. We need a long time, almost 12 years. We need both, of course, clinical data also. So approval, it's not a big issue right now, and we have this fast track to make it easier. Regarding management, we have two levels, home care and we have hospital care. Regarding home care, the main issue is to focus on prevention of transmission to others. Of course, there's no medication to be used to reduce the transmission or to as a prophylaxis. We don't have any medication for this, but we are trying to use non-pharmacological ways to inhibit or to reduce the transmission. Regarding the outpatients, we are only giving some symptoms relief medications like antibiotics, analgesics, and of course, all of them should have a good hydration. Regarding hospital care, we have a lot of medications. We are talking about pharmacological management only. We have glucocorticoids, nebulized medication, NSAIDs, antimalarial, antiviral, interleukin-6 pathway inhibitor, convalescent plasma, and vitamin C and zinc. I will go through all of those briefly, and I will give you the final recommendation. Then I will shift to the our KSMC protocol. Regarding glucocorticosteroids, we have one good versus two bad studies before or experiences before. The first one with SARS, there was a good outcome. Sorry, there was a bad outcome. It was led to increase for mortality, and with influenza, delay with the viral clearance with MERS-CoV. So CDC and WHO recommend that glucocorticoids should not be used in patients with COVID-19 unless there is other indication. For the sake of COVID-19, we are not using any steroids, but for other indication like exacerbation, COPD exacerbation, or status asthmaticus, or for ARDS. For ICU patients, there's special consideration for steroids, that ARDS. We are using only with severe ARDS. If the ratio is than 100, I think Dr. Bassem maybe in this BO2 over FiO2 ratio. If less than 100, we can use methylprednisolone. This is the suggested dose. It's very high dose for us. Usually we are using 1 milligram per kg, but they are suggesting with COVID-19, you may reach 400 milligram per day. Sometimes also with those patients with septic shock, we are using hydrocortisone. So hydrocortisone can be used, but also for the sake of septic shock. The dose 50 milligram IV Q6 hours. Regarding nebulized medication, of course, we are its use is prohibited, and we are trying to avoid any use of aerosol generating procedure. So nebulized medication should not be used. And if you want to give bronchodilators, you can use it by giving the meter dose inhalers instead of nebulizers. And if there is any other medications rather than bronchodilators, sometimes we are giving, let's say, some antibiotics via nebulizers. So you have to stop those adjunctive therapy and antibiotics via nebulizer. We know that the IV is the standard of care, but sometimes we are giving some nebulizers with like antibiotics as adjunctive therapy. It's contraindicated and should be stopped for those patients with COVID-19. Regarding NSAIDs, I think on 18th of March, 2 months ago, WHO, they announced that some French scientists, they found that NSAIDs may exacerbate the signs symptoms of, especially ibuprofen will exacerbate signs and symptoms of COVID-19, and some younger or young patients, they have more complication if, with history of using ibuprofen during COVID-19. But after that, many studies showed there was no effect of NSAIDs and anti-inflammatory drugs in general for those patients with COVID-19, and there is no risk to have or to experience more severe disease. So the EMA, which is the European Medicines Agency, WHO, do not recommend that NSAID be avoided when clinically indicated. So we are not using usually NSAIDs in the ICUs, but you can use it if you have to, or if the patient is using these medications chronically. So if you have to use it as antibiotics, of course, you will try acetaminophen. If there is no allergy, you will start with acetaminophen first. But if there is no good response, you can use NSAIDs, but with lowest effective dose. And try to use it with the lowest effective dose. And you can use for any other indication. If the patient with rheumatoid arthritis, they can resume their NSAIDs unless there is contraindication related to the drug itself, like acute renal injury or GI bleeding. This is not related to COVID-19. So our regular use, usually as antibiotic, we are using paracetamol or acetaminophen. But if there is no good response, you can start NSAID, but try to use it with lowest effective dose. So no harm of using NSAIDs with COVID-19 patients. For those antimalarial drugs, chloroquine and hydroxychloroquine, it also used to manage and minimize symptoms of inflammatory immune diseases such as lupus and rheumatoid. In vitro, they found those medications may have some effect with SARS-CoV-1 and SARS-CoV-2 viruses. So they are preventing the attachment and the entry to the cell. So in vitro, there was some good activity. But we have many side effects with those drugs, and we have to be wise while using those. Why? Because we don't have also a definite data that or information that those drugs are in vivo effective for COVID-19 patients. We cannot recommend those drugs to be used because there is no change in mortality with those patients using hydroxychloroquine or chloroquine to other patients. So we have to use them. We don't have other choices or much choices, but if there is some side effect or major side effect and the risk outweigh the benefit, you can stop and do not use. Like what? Like QT prolongation. We have those patients the patient may arrest with this QT prolongation. So we advise if the patient under 40 and there is no respiratory symptoms or severe respiratory symptoms and the QT more than 500. So the risk of using hydroxychloroquine will be outweigh the benefit. So do not use hydroxychloroquine with those patients. But with elderly, advanced age patient, immunocompromised patient, a lot of comorbidities or many comorbidities, you can use them. But if the QT more than 500, you have to consult cardiologist with this medication. Also, you can consult a clinical pharmacist that they can check drug-drug interactions, and they can reduce or discontinue other medications may prolong QT prolongation with this antimalarial drug. So if you want to start with sick patient, immune-compromised, advanced age, comorbid patient, you can use hydroxychloroquine, but you need to check the QT. If it's prolonged, you need to consult cardiologist and clinical pharmacist. If it's not prolonged, you can start. Regarding hydroxychloroquine, it appears to have more potent antiviral activity than chloroquine, but both of them have in vitro they have activity. But for the FDA issue an emergency use authorization, as I mentioned, fast track authorization to use the hydroxychloroquine and chloroquine. Optimal dosing, till now we don't know the optimal dose. For many studies showed some benefits or some effect with hydroxychloroquine with different doses, but the standard dose we are following 800 milligram on day 1, which is 400 BID, then 400 milligram daily, which is 200 milligram BID. And regarding chloroquine, we have 1 gram on day 1, then 500 milligram daily, but please check if it's the chloroquine base or the chloroquine sulfate. If chloroquine sulfate, the dose will come 1 gram. If chloroquine base, it will be 600 milligram because there is no weight for the salt. So if it's the base, the dose will be lower. If it's if it's a chloroquine sulfate, the dose will be higher, reach to 1 gram. Okay, and this study not yet published and not yet reviewed in a peer-reviewed journal, but it shows that hydroxychloroquine may have some, with a small randomized controlled trial, they will show that it will resulted in faster time to improvement in fever, cough, and chest imaging findings. But till now, we have don't. Till now, I cannot find it as a published study. Regarding to toxicity and side effect, up to 90% of the patient, they will not have any side effect or toxicity with the chloroquines and hydroxychloroquine, but others we have to make weighing for risk and benefit. But till now, the major issue, do we have a definite answer that antimalarial drugs are beneficial with COVID-19 patients? We don't know. This is the major issue, that if you want to weigh, you will weigh the benefit. But which benefit? We don't know if they are really effective against COVID-19. But do we have to use? Yes, we have to use. Till now, we have to use because we have no other alternatives to not miss the chance of benefit or the possibility of this benefit we are using. But regarding drug toxicity, we need to check, of course, QT prolongation and retinal toxicity. And we try to reduce other drugs. They may enhance this toxicity by drug-drug interaction, and we need to monitor those adverse drug reactions. Regarding the QT prolongation, this is a small or detailed graph regarding the using of hydroxychloroquine and the chloroquine. If you want to use, first you can check QRS. If it's prolonged already, this one more than 120, so you will go to the QT. If QT less than 520, you can start immediately hydroxychloroquine. But between 520 and 550, the QT, you need to start with caution. That means you will call a cardiologist. But with QT prolongation more than 550, you have to wait till you have cardiologist permission. And if there is any increase in QT more than 50 or at any time the QT more than 550, you have to stop and to call a cardiologist. But if we have QRS less than 120, so if the QT less than 470, you can start immediately. If the QT between 470 to 500, you can start and then consult cardiologist. But more than 500, do not start till you have cardiologist permission. And as usual, if you have any prolongation with more than 50, increase more than 50, so you have to stop and consult cardiologist. Regarding to this one, almost the same, but I need to mention that you have to optimize magnesium and potassium. So rule out other risk factors for QT prolongation. As I mentioned, try to consult clinical pharmacist to discontinue any other medication that can cause QT prolongation and to decrease any chance of drug-drug interaction. And optimize by yourself the magnesium and potassium before you will check QT. Last slide, because regarding to anti-malarial drugs, the common side effects. I mentioned that you need to monitor side effects, you need to monitor ophthalmic side effects, hematological, of course, hemolysis in those patients with the glucose 6 phosphate deficiency. But we need to know that chloroquine, it's very common with chloroquine rather than hydroxychloroquine, much lower with hydroxychloroquine. So when you will start chloroquine, you need to send the G6PD test before you will start to avoid hemolysis. Leukopenia, thrombocytopenia, even endocrine with those patients using insulin, severe hypoglycemia, you may say, because those patients are insulin dependent, the sensitivity of the insulin will increase with the use of chloroquine and hydroxychloroquine, so you may face severe hypoglycemia. Cardiovascular, as we mentioned, QT, respiratory, there is some bronchospasm, and hepatic, you will find abnormal hepatic function test. Usually we are not holding the hydroxychloroquine unless it's more than the normal, upper normal by 5 folds. The last information regarding hydroxychloroquine, you need to know that even we are using this for 4 to 7 days according to the recommendations, but the half-life, it's very long, up to 40 days, or it reaches 40 days. So when you are using this one for 7 days, you are not using only this time or this period. Side effects may stay up to other 40 or 50 days. Regarding remdesivir, this is IV novel nucleotide analog. We are thinking that it's a broad spectrum antiviral. It's active against SARS-CoV-2 in vitro. The usual dose 200 milligram as a loading, then we will give 100 milligram once daily for 2 to 10 days. But most of the recommendation 7 to 10 days. It's a broad spectrum, as I mentioned. It's also in vitro, some activity with SARS, MERS, and it was used for or tested with Ebola, but unfortunately it failed with humans. Mild side effect, which is good, but as you can see in the title, in the practice, I mentioned it's not an ICU drug because there is many exclusion criteria. We need to exclude the use of remdesivir when we are treating our patients in the ICU. You can imagine that you should exclude those patients with multi-organ failure, need to inotropes or vasopressors, those patients in shocks, and with those patients with creatinine clearance less than 30, or those patients on dialysis, hemofiltration, and those patients with acute liver injury with high liver enzymes, and the use of other antivirals. So there is many exclusion criteria to be used, and I think the patient will enter the ICU, maybe 70 or 80% of our patients will have 1 or 2 of those. So it's not an ICU medication. And there's another issue that the cyclodextrin vehicle, it's solved in the cyclodextrin, so Also, with those patients with acute renal failure, they may have severe toxicity if acute renal failure occur while they are using this drug. But according to the recent data, more than 1,000 patients, they found that remdesivir likely has some clinical benefit. Likely. It's not a solid also evidence. They think that it may help, but help in what? For those, the data of randomized trials, more than 1,000 patients, they suggest that remdesivir result in faster time to recovery, median 11 versus 15 with a placebo. And there was a trend to have lower mortality rate, but it's not statistical significant, 8 versus 11.6. But the number of patients, more than 1,000, it was enough to have this statistical significant, but it was not statistical significant. So till now only it will may or result with a faster time to recovery. But in contrast, there was another study also from China, that one was from US. The other study from China with 237 patients with severe COVID-19, remdesivir and placebo had similar times to clinical improvement and similar rates of mortality. So we also don't have solid data regarding to this, but what we know, remdesivir will not help in mortality. Till now, we don't have any proof that it will improve the mortality. Regarding to the Chinese study, there is no help. Regarding to the state study, there was some benefit and it's not statistical significant for the mortality. But regarding to the first study or the first one, the recovery will be faster with remdesivir. Okay. Regarding lopinavir and ritonavir, we are using those medications since March, I think, but unfortunately in the vitro there was good results, but appears to have a little or no role in the treatment of COVID-19 infection. According to this study, almost 200 patients with severe COVID-19 giving leponavir, ritonavir with the maximum dose 400 milligram and 100 milligram twice daily for 14 days. There was no benefit. And the mortality 28 days, at 28 days, the mortality at 28 days, there was no change and no difference. So we are in our protocol, we are recommending that you should be used only after ID approval. We are not using lopinavir, ritonavir for any ICU patient, even with severe COVID-19 infection. The ISCIM, the European Society of the Intensive Care Medicine and the Society of Critical Care Medicine and Surviving Sepsis campaign recommendations suggest against the routine use of lopinavir, ritonavir in critically ill adults with COVID-19. So in ICU, there is no rule for lopinavir, ritonavir unless there is ID recommendation. Favipiravir, it's a Chinese drug. It's only available for Asian countries. We don't have it here in Saudi Arabia. Even in the COVID-19 protocol, MOH COVID-19 protocol, it's there, but till now we don't have it. It's RNA polymerase inhibitor, and there was some good results when they used the favipiravir. In this study, they found that faster rate of viral clearance and more radiographic improvement, but the limitation was they are using with patient with oxygen saturation more than 93%, so non-severe cases, and it's not randomized open label study, and the result was with other managements. They didn't compare with the without the favipiravir without any other management, even with this low severity. So we need to be careful with this study, and most of the protocols, they are not recommending to be used as a first agent, and we need further study to decide. But one thing we need to know that it's contraindicated for pregnancy, and even male must avoid intercourse for 4 weeks if they used favipiravir. Convalescent plasma, they took the plasma of COVID-19 patients. They recovered from COVID-19 with PCR negative, and they are trying to give this plasma with antigen antibody for COVID-19 to sick patients. Small studies for this one, only 5 patients were checked with severe COVID-19, but the results was good. But unfortunately, with the experience with Ebola and MERS-CoV, the result was not conclusive, and they did not recommend to be used for all patients. But as a last therapy can be for the MERS-CoV recommendation. But here in COVID-19, we still need more data. Of course, there is some issues regarding the logistic challenges, because you have to nominate donors and recipients, and to collect those plasma through plasmapheresis, then to find the titer of the antibodies you need to transfer for the recipient, and to give. So there's many logistic issues, and it needs a big team, and there is some challenges. Regarding interleukin-6 pathway inhibitors, this is not a COVID-19 treatment, but some of the complication of COVID-19, which is cytokine release syndrome with elevated of interleukin-6. So we are giving tocilizumab. This drug can reduce the cytokine release syndrome and decrease the severity of illness with those patients with COVID-19. So it's not affecting the virus itself, but it will decrease the complication. There is other drugs with these interleukin-6 pathway inhibitors, sarilumab and cetuximab, but till now under investigation, and the only one approved for this indication with COVID-19. It's not approved, by the way, one small retrospective study, but in most of the protocols where they recommend to use tocilizumab, because it's the only one tried till now. Regarding vitamin C use, this is also not antiviral therapy. It's a supportive therapy. Most of the time, we know that the immunity of our patients will be linked with vitamin C level. Usually, we need a very small quantity of vitamin C, which is 0.20 gram per day. But with septic patient and ventilated patient, ICU patients specific in general, they need much higher doses, reach to 6 gram per day. So we start to use vitamin C in the ICU for most of septic patients. There are some trials regarding septic patients and those patients with respiratory issue. But they found those patients with ventilator, and they are ventilators, and they are using vitamin C. There was a very good results that the length of stay in the ICU was reduced by 7.8%. And the duration of mechanical ventilation was reduced to 18%, even some studies 24%. But the average was almost by 18%, which is very good result. But regarding to COVID-19 specifically, we don't know. But for those patients with ventilators, if you can give those patients vitamin C, start and give them this medication. Regarding to the dose, it's vary. But usually we are giving 1 to 6 gram per day. Regarding the COVID-19 protocol, or according to COVID-19 protocol, we are giving 2 gram Q12 hours. Okay. I think zinc slide is missing. Regarding to zinc, it's not that beneficial drug. There is no data regarding COVID-19 with zinc. And there's a lot of toxicities when we are using on regular way. Of course, in this short duration, we are trying to give higher doses of zinc. So the risk was outweigh the benefit. So they stop the use of zinc with those patients till now, unless we have a level. Now I will go to the protocol. our cluster 1 protocol for COVID-19. Oh, this is the slide of it. Okay. So as I mentioned, we have the hospitalized patient, but for those hospitalized patients, we have also two categories, suspected cases and confirmed cases. For suspected cases, as any ICU case, you need to give DVT prophylaxis, regular dose, and omeprazole, regular dose also. If there's any need for antibiotics, you can give, and medical management as usual. But for those patients with confirmed case, first thing you have to, of course, for ICU patients, you have to consider convalescent plasma as soon as possible if it's a critical case. Of course, this decision will be taken by ICU consultant. Regarding those patients, if we don't have any contraindication for anticoagulation, we need to start anticoagulation for them as prophylaxis. But you know, with COVID-19, there is a lot of issues regarding coagulopathy, and many studies suggest that those patients may die from thrombosis, arterial or venous thrombosis. So the use of DVT prophylaxis is special here. We will check the DVT risk with D-dimer. If it's low, we will give enoxaparin as regular according to the weight. If the weight less than 100, we will give 30 milligram Q6, but more than that, we will increase the dose. We have a chart that I will show you by the end of my presentation. It's very easy for you to decide the dose. You don't need to remember or to save those doses. Okay, any antiviral will be used should be under ID after ID acceptance and consultation, because most of those antiviral we are using for other indications. Some of them like lopinavir, ritonavir, we are using anti-HIV drug, so we don't need to emerge resistance for those drugs without any benefit to the patient. So any antiviral will be used after ID consultation, except oseltamivir, which is Tamiflu. We are using usually for those patients with suspected pneumonia to rule out influenza and viral pneumonia. Routine use of corticosteroids, as I mentioned, it's not indicated, and we are only using those for COPD, asthma, septic shock, ARDS, as in for the other indication with the specific dose of the other indication. We need to send the G6PD to screen for screening if we will use chloroquine. Vitamin C, you can give 1 gram BID, as I mentioned, 1 to 2 gram BID. Vitamin D also can be used. Thiamine, magnesium. Magnesium we need to correct to avoid QT prolongation. For confirmed cases, moderate.
We have limited time only. Sorry for interrupting. We have limited time. We have limited time. I mean, could you summarize, please? Thank you.
Regarding to the protocol, we divide the patient according to the severity. So we have mild to moderate and severe and critical. For mild to moderate, if there is no respiratory symptoms, young age, and there is risk for QT prolongation, we will not give anything. But if there is comorbidity, immunocompromised patient, and no QT prolongation, you can use hydroxychloroquine. But if you have any issue with the QT, you should consult cardiologist. Also, for those COVID-19 patients, we are trying to, or we have to treat pneumonia with ceftriaxone, azithromycin, oseltamivir, if indicated. And you need to rule out pneumonia also. If hydroxychloroquine not available, you need to use chloroquine, but the primary or first choice hydroxychloroquine. For those severe cases, also you will start hydroxychloroquine immediately if there is no QT prolongation. If there is QT prolongation, you need to wait till you have a cardiology opinion. Sometimes we will start lopinavir, ritonavir after ID recommendation. Regarding to pneumonia, we will escalate our treatment. We will use beptezo and azithromycin, and sometimes we may use vancomycin. Regarding to andulafungin or echinocandins, we are using if the patient in septic shock. Regarding to the critical cases, those cases will be managed by ICU consultant, of course, and most of the order, but you need to give hydroxychloroquine again, remdesivir, favipiravir if we have. Since we have it, we will start to use remdesivir and favipiravir. Also, we will treat bacterial and antifungal drug like amphotericin B, but after again ID consultation. ICU consultant has the license or the privilege to use tocilizumab only for those patients with suspicion of cytokine release symptoms. Those are the doses. You don't have to remember. Only from looking to the protocol, you will find all doses and regimens, also the duration. And last thing, I want to show you the last slide about the anticoagulation therapy. The last slide is here. Can you see this one?
No, Dr. Bashir, no.
Only 1 minute. I will. Now you can see?
Yes.
Okay. So we have suspected, as I mentioned, we will treat as any other patient in the hospital, but for confirmed, if there is no hemorrhagic risk or no hit, you will go to the D-dimer. If D-dimer is low, you will go according to the weight. You can see here, according to the weight, you can give the appropriate dose. If there is renal impairment, creatinine clearance is less than 29, we will use heparin instead of enoxaparin. Of course, enoxaparin is preferred over heparin for COVID-19 patient, unless there is contraindication like HIT, we cannot use enoxaparin, or like creatinine clearance less than 29. If the D-dimer is high and we have high risk for but not approved DVT or BE, you have to contact hematologist, of course, and continue screening regarding the DVT and BE, and you have to give according also to the weight, but higher doses than those. So you can see here for those patients more than 100, we will give 80 milligram every 12 hours. And if there's renal impairment, we can use heparin with higher doses, 7,500 international unit every 8 hours. So this is the chart, and you can read. Please ask me if you have any questions, and thank you very much.
Thank you, Dr. Bashir, for a very informative lecture. So there are some questions. Can hydroxychloroquine used for prophylaxis?
No rule for any prophylaxis. Of course, most of the patients with hydroxychloroquine, there is high risk for QT prolongation, and should be we should to make a daily or ECG when we are using hydroxychloroquine. So it's not indicated as outpatient, and it's not indicated as a prophylaxis. Regarding G6PD, yes, should be sent before that treatment. Immediately when you order chloroquine, you need to send. But for hydroxychloroquine, no need to send. The risk of hemolysis is much lower with hydroxychloroquine. Regarding vitamin D as the vitamin C, they mentioned that the immunity and the outcome with those patients with COVID-19 may be better with those patients with good vitamin D level, but specific rule and specific relation between vitamin D and COVID-19 till now we cannot find, but those patients with high level of vitamin D has or have good immunity, so their outcome was better. What is the role of plasmapheresis?
I think this plasmapheresis, it will be discussed by Dr. Wadat in his lecture of acute kidney during COVID, and he will touch this.
Yes, this will be explained in details with Dr. Wadat lecture, inshallah.
Thank you, Dr.
Bashir.
Thank you very much. And we are moving to next speaker. Next speaker is our senior IC consultant, Dr. Balshi. He will present a topic of also very important topic related to current COVID-19 pandemic. It's pneumonia. Pneumonia is one of the severe complication of COVID-19 leading to high morbidity and mortality. So welcome, Dr. Balshi. Can you share your slides, please?
Are you hearing me?
Yes, Dr. Balshi.
Can you give me just 2 minutes to fix the slides to share it? I have a problem with the program. Wait. Because it's my lecture. Wait. I have some technical issue, but well,
Dr. Balshi, just sound of microphone. Can you increase the sound,
wait,
please?
Is it my voice clear or not yet?
Right now, clear, yes.
Yeah, but exit or minimize video. Wait, I don't know how to use. Oh, okay. Share screening. Wait. COVID updates. Okay. Share. Is the screen appearing now?
Yes, Dr. Balshi, screen appearing.
Okay, wait.
Just thank you. Yes,
It's
clear
it's,
now.
it's okay now.
Yes, Dr. Balshi.
طيب. Assalamu alaikum. Good evening. I'm happy to be one of the part of this course for non-ICU patients, for non-ICU physicians. Special thanks to the committee and for the Dr. Madi, Dr. Gultakin, and Dr. Ahmed Kuhail. My lecture today about the pneumonia and COVID-19, but it's actually interfering with most of the lecture what you are heard before in this course. Just to be updated until now, today, or actually tomorrow, we have 4,400,000 cases in the world, and with around 300 deaths, 300,000. But in Saudi Arabia, we are increasing in numbers, around 44,000 until today, and the death 273, which is around 0.6% death, which is the lowest than other countries in the worldwide. The death percentage was around 7%. This slide just to tell you that COVID-19 is not is a pandemic, and really it's an important topic, and all physicians should know about the COVID-19, what how we can approach the patients, how we can manage the patients, how we are taking precautions from them to avoid getting infection. First of all, I just want to highlight some abbreviation. When we are talking about COVID-19, we means the disease itself. Means COVID-19, it's a disease, coronavirus disease 2019. This is diagnosis. But when we are talking about the virus name, we will talk about SARS-CoV-2, severe acute respiratory syndrome, coronavirus 2. This pandemic, as we know, it started in 2019 in Wuhan, in China, in the seafood or animal markets, and it causing an outbreak in the world. The clinical presentation of the patients is resembling any pneumonia, and it's more severe in patients who have comorbidities and older age, but it can affect any age. But children usually have mild symptoms. Sometimes they will not present even with fever. Put in your mind very important points that patients who are asymptomatic, they found that they have similar viral load comparison with the
people who are symptomatic, which meaning patient who is asymptomatic can be highly infected to others. About 80% of people recover from this disease. They doesn't need any special treatments. Transmission, it was talked before about it. It's droplet transmission, and patient can be infected direct from other person when he is coughing or sneezing directly, or if the infected person who coughed or sneezed on any surface, then the other healthy people who touch these surfaces by his hands, then he touch his eyes or mouth. That's why it's important to do hand hygiene and clean our hands. Droplet is not like airborne. Droplet is more heavier. It's not travel more than 6 feet, which is about 2 meters in the air. And but in some certain situations, when we have aerosol generation procedures, the viruses can stay or remain in the air for the 3 hours. Therefore, airborne precautions are recommended only for healthcare workers when they are doing an aerosol generating procedures. The pathophysiology, as we know, and that this virus have a spike of S protein, which allow attachment to the epithelium of the alveolar and lung epitheliums, and replication started more higher, and then patient will have the release of the pro-inflammatory cytokines and chemokines, which result of uncontrolled systemic inflammatory response, which called cytokine storms. What about COVID and pathophysiology of the COVID? I think there is good lectures given by our colleague, Dr. Waqas, about the pathophysiology of the COVID-19, and about Dr. Gattanoni. He's a German anesthesiologist who was first one who is reviewing these patients, and discovered with his colleague that there is 2 types of COVID-19, which is type L and type H. For type L, what is meaning by type L? As we know, it's coming from the L low. Everything is low. Low resistance, low VQ, low lung weight, low recruitability, means the patient doesn't need recruitment. Still, lung is little bit healthy, and that's why it doesn't need high beep. In other part, H type, we have high elastance, means low compliance, high right to left shunt, high lung weight, because it's mimic like ARDS, but it's not ARDS actually. High recruitability means that lungs can be recruited. That's why we need high beep. This is the CT scan of patients with COVID. As we saw, as we see here, the low VQ in the CT scan still lung little bit healthy. There is a patchy infiltration, ground glass opacity, but when we have high type, the lung already become stiff, heavy, and need recruitments. Okay, what about the clinical features? As we know, the incubation period is 14 days, and the disease itself have mild and severe and critical. Mild cases is around 81%, and severe diseases, we found it in the around minimum 14%, and the critical diseases in around 5%. But don't forget that even mild cases can transfer to the severe, and severe cases can go to critical situation. What about virus shedding? Virus shedding is highest early in the course of disease, as we say, asymptomatic patient, prior to start the symptoms, patient will have higher shedding of the virus, and it's occurred 24 hours to 48 hours prior to the symptoms. Viral shedding usually continued to 7 to 12 days in mild to moderate cases, but in severe cases, it can continue up to 2 weeks. Patient who recovered can be PCR still positive after symptoms resolve. How we can differentiate between bacterial or viral pneumonia? Our COVID-19 is a viral disease, but is there any way to differentiate between bacterial and viral? Actually, it's difficult to differentiate between them. However, the COVID-19 become more prevalent in the community. That's why we are suspecting any patient coming with symptoms of pneumonia, we are putting him under suspicion of COVID-19 until proved otherwise. But in viral pneumonia, there is some points which is more likely that patient having COVID viral pneumonia. When patient present with when patient has a severe muscles pain, myalgia, has loss of sense or smell, the breathless, has no pleuritic pain. This is most important. No pleuritic chest pain, and has a history. Patient will have a history of exposure to unknown or suspected COVID-19. But in bacterial pneumonia, points forward to bacterial pneumonia when patient become rapidly unwell after a few days of symptoms, does not have history of typical contact with COVID-19 or symptoms of COVID-19. He has pleuritic pain. This is important, and has a pleuritic sputum. As we know, COVID-19 patients have most likely dry cough. Clinical presentation, the commonest one is the fever and dry cough. Patient fatigue and sputum production sometimes. Shortness of breath is common. Less common, as I say, myalgia and arthralgia, headache, sore throat, and chills. Nausea, the GI symptoms also rare, but can be. But don't forget also the loss of sense and taste. Right. In this tables, it's well explained by our colleague, Dr. Madi. Just I want to say in this, this is the stages of the COVID-19 patients. When the first stage is asymptomatic, second stage symptomatic, but no evidence of a pneumonia. Third stage is a pneumonia and or pneumonia with hypoxia. The fourth or fifth stage critically ill with shock or multi-organ failure, ARDS. Most of the patient entering ICU in the stage 4 and 5 when having pneumonia and hypoxemia and or critically ill with shock. And mortality in ICU is very high for COVID patients who are intubated. It's ranging between 50 to 70%, and approximately around 60%. What are the complications of a pneumonia of the COVID-19? The most common patient coming with a pneumonia, sure, acute respiratory distress syndrome, and acute cardiac injury, secondary infection, sepsis, acute kidney injury, and multi-organ failure. Right. What about the pathophysiology? Our physical examination. Physical examination, as same as any pneumonic patient. In auscultation, you will have inspiratory crackles, rales, or bronchial breathing, respiratory distress. Patient can come with tachycardia, tachypnea, and cyanosis or hypoxemia. Next, the questions: what the most common chest X-ray finding in the COVID-19 patients is bilateral lung infiltrates, and it's correlate with the degree of hypoxemia. Is this true or false? There is a pooling coming or no? Ahmed? Right. For sake of the time, the answer here is false. Why? Yes, the first part of the questions, the most common chest X-ray findings in the COVID-19 patient is bilateral lung infiltration. This is true, but it does not correlate with the degree of hypoxemia. Means if sometimes you will find very bad chest X-ray, but patient is not hypoxic, and sometimes you will find patient with good chest X-ray or minimal abnormalities, but patient is severely hypoxic. Imaging in COVID patients, it should refer to the policy of the hospital. In our hospital, the first line imaging is chest X-ray. You have to order chest X-ray in all patients with suspected pneumonia. What about CT scan? CT scan, is it more sensitive? Yes, it's more sensitive. That's why chest X-ray is less sensitive than CT. But we cannot order CT scan for all patients of the COVID just to minimize the exposure to healthcare worker and for radiologists. We will leave the CT scan if there is other indication for patients who needs really the CT scan, like trauma patient. If I am going to do CT scan because patient have trauma, to rule out intra-abdominal bleeding, to rule out BE, then I will go for CT scan. Otherwise, chest X-ray and ultrasound, it will be enough. And we will talk about the next slide. But when you are ordering the chest X-ray, please use the portable device, which is preferred. Why? Because we are minimizing, again, transporting patient to radiology department. As we say, the chest X-ray may be normal or in early or mild diseases. The most common findings in chest X-ray is the bilateral lung infiltration, which is found in 75% of the patients. Unilateral lung infiltration found in 25% of the patients. And the infiltration, most of the cases, is peripherally infiltration. And from our experience with the COVID patient in our hospital, around 80% of the chest X-ray, what I facing are having typical peripheral infiltrations bilaterally. This is one of the COVID patients, 19 chest X-ray, who are intubated with central line. Let's go to the chat. Yes, wait. Okay. Next is ultrasound, point of care ultrasound focus. Ultrasound now have a big role in COVID patients, or in general in ICU patients. Why? Ultrasound is very important radiological study, and really it's equal in sensitivity to the CT scan. If I want to say to look for consolidation, infiltration, pleural fluid, pleural thickening, it's good modality, and it's very important because I can do it thrice per day in each shift for my patients, and no need to shift my patient to CT scan for radiology department to do CT scan. I can get all information what I want from the ultrasound, except some of the like BE. I want to confirm. Sure, for BE I need BE protocol, a spiral CT or angio to confirm the BE. But what are the following patterns was observed in ultrasound chest? The most common findings is multiple P lines. We'll explain what is P line. Irregular thickened pleural line with scattered discontinuation, subpleural consolidation, and alveolar consolidation. All can be, these are the findings on the ultrasound in COVID patients. By way, pleural fusion is not common, and lymphadenopathy is not a common features of COVID patients. When you are using the ultrasound, use please the low frequency probe, as we see here in this photo. And as we see here, this is the real ultrasound. So we can, this white lines is the vertical lines. It's what's called B lines. This is B lines. We have here 3 B lines. We have here scattered and confluent B lines. Here we have consolidation. This is the white area, and large consolidation here and here and here. This is just to show you the ultrasound, what is meaning. This is normal ultrasound for patients who is healthy. What is the normal ultrasound findings is A line. This is the A line. This is the A line. As we see here, it's transverse lines. As we can see it here and here. This is the A line. But in a patient who has consolidations, we will see the B lines, as we can see here, vertical. This is B lines, scattered B line shadow. The black one is the ribs shadow. This blacks between is the rib shadows. Right. This is scattered B lines here also, as we can see it, B pattern. It's moderate and severe pulmonary diseases. And here can show you what is the consolidations in the lung. This is the lung, and this is the consolidation with white spots inside, which is air bronchogram. To know what is the sensitivity of the just these photos to compare the CT scan with the ultrasound findings, as we can see here, this is the CT scan with ground glass or consolidation in this area, and it's really equaling to the ultrasound with B line, 2 B lines here, which is reflecting the infiltration in the lungs here. What a CT scan, as we said before, it's not first line imaging for patient with suspected pneumonia, but I need it. We really need to confirm BE on the patients, or if the patient is going for other indication for CT scan, other part of the body. CT scan is the evidence or features abnormalities may precede the development of the symptoms and even prior to the detection of PCR on patient with the COVID-19. That's why initially in the China, the CT scan was the primary imaging of modality there. For those who cannot differentiate what we are talking about, what is the consolidation, what is the cavitation, what is the ground glass appearance, which is opacities, which is the most common findings in the COVID-19. Here is the ground glass opacities, as we see here, and nodular infiltration lesions, and this is septal thickening, and this is the cavitation and consolidation with air bronchogram here, and this is the pleural effusion. Just to differentiate between what is the ground glass, what is the pleural effusion, how can appear in the CT film. Right. What is the most common findings in CT chest? It's ground glass opacities, which can be bilateral, subpleural, or peripheral. Crazy, other abnormalities is crazy paving appearance, airspace consolidation, bronchoalveolar thickening, and traction bronchiectasis. It's not routinely recommended, as we say, to avoid what? To avoid unnecessary exposure during transport of the patients. Right. This is a real CT scan of a patients with COVID-19. Different section. You have here the peripheral ground glass opacities. Here is the ground glass opacities, infiltration, peripherally. Right. We will move to the molecular testing. Molecular testing is required to confirm the diagnosis of the COVID. What we are meaning. Perform real-time PCR for all patients with suspected infection. How we can take the sample? We will take the sample from upper respiratory tract, from nasopharyngeal aspirates or oropharyngeal swabs. In patient who is not intubated, who is spontaneously breathing. If you have patient is intubated already and still sample not taken before intubation, or then you go to the sputum sample. You can go for endotracheal aspirate or bronchoalveolar lavage when it's possible, if patient intubated, according to the condition of the patients. Type. Question: the highest rate of positive real-time PCR result in COVID-19 patient is? What is the answer? Is it A, bronchoalveolar lavage, or sputum, or nasopharyngeal, or oropharyngeal swabs? The answer, Ahmed, there is polling or no? Yeah. The answer, some of them say A, some C, according to the chat. The answer is, let's see the polling now. I think all will answer the right way. It was presented before in other lectures. I'm waiting for the finish of the polling. Okay. Muhammad, Riaz, Abdul Rahman al-Nasir, answering through the chat. Please answer through the polling. Okay, we'll stop here. What I noticed that 85% finished the polling, 85% answered A, BAL, and C, nasopharyngeal swab is 25%. Right. The correct answer is A, bronchoalveolar lavage fluid BAL. Right. We'll see. Okay. In this table, it will show you the percentage of the positivity of the bronchoalveolar lavage fluid. It's very high. It's around 93. But in nasopharyngeal nasal swab, around 63 or 66, and the pharyngeal swab is around 33. The highest is for BAL, yes, but we cannot go for BAL for all patients. Why? Because it's really arousal generating procedures. When I will go for BAL, when all results came negative, swabs, nasopharyngeal, oropharyngeal swabs, which is repeated, also negative. When I have also sputum result negative, and still I have a high suspicion of COVID in these patients. If you compare both together, nasal swab plus pharyngeal swab, the sensitivity will be higher, because nasal swab detected only in 2/3 of cases, and pharyngeal swab detect 1/3 of cases. If I compare both together, I will have higher sensitivity. Then, if initial test is negative in patient who strongly suspect COVID, then I have to repeat the sample. If patient intubated, then I will go for sputum, endotracheal aspiration. Blood and urine and stool, yes, it can be positive, very minimal sensitivity percentage, but it's not for diagnosis. Now, what are the recommendations from all? Please don't order sputum induction. Don't tell the patient to cough to get sputum sample and send it for COVID, because it will be highly contagious and infected for other healthcare workers. Avoid bronchoscopy unless absolutely indicated. Pulmonary function test or spirometry are not indicated. Airborne precautions for aerosol procedures such as intubation. This is the aerolizing procedures: intubation, extubation, non-invasive mechanical ventilation, and open circuit. Please avoid all of this procedure unless it's indicated. If you failed the N95 fit test, because of you having facial hair, or please consider the power air purifying respirator parts. And this is the photo picture of the parts. We have it in our hospital, one for each healthcare worker. Type. We will go to the next step, which is COVID-19 rapid test. What about COVID-19 rapid test? Which is better, COVID-19 rapid test or the PCR? We will see. This is the test. Okay. This test, it's done within 10 minutes from the blood. We will take one drop of the blood of the patients, and we'll put it in the device here, and it will show the result within 10 minutes. But is it accurate? Is it recommended to be used? We will see. Why? Is it yes or no, and why? This diaphragm will show you this is the window period for the patients, and here patient become symptomatic, and here start to be recovered. For this molecular test, when patient is asymptomatic, we cannot detect by rapid test. We cannot detect the patient who are positive. That's why don't use rapid test until symptoms have been present. In this area, patient will have false negative results. Then from the green here, the IgM, this IgM, it will start detected around from day 7, right? And symptoms, as we know, started at around day 3 to day 5. And the IgM, the rapid test will start to be positive on day 7, and the IgM of this test will continue up to 21 days. But IgG, which is starting from day 14, means patients start to be recovered, and IgG remains in the blood positive later on. And this is the interpretation of this rapid test. With comparison of the PCR, when you have, this is the rapid test, IgM and IgG, when you have both are negative and PCR positive, means the patient is in the window of period of infection. But if you have IgM positive only, with sure PCR will be positive, patient in early stage of infection. If IgM, IgG, PCR positive, patient in the active phase of infection. If IgG start, sorry, we'll go back. If IgG start to appear, then means patient in the late stage of the infection, or really he start to be recovering. And the PCR negative and IgM positive and IgG negative, patient may be in early stage of infection, and PCR in this way, it should be positive like here, like the second line, but maybe it's false negative. That's why, because of technical taking of the swab, maybe it's false negative. If you have IgG alone is positive, means patient had past infection and he recovered. Okay. And if you have IgM, IgG positive, it must be the PCR positive, but maybe that's why it's called false negative patient, maybe a recovery phase of the infection, and PCR may be negative. This is the different picture of the rapid test. Here, as we see here, IgM and IgG are both negative. This is the control, must be appear in all tests. If IgM and IgG negative, as we see here, this is the one patient may be in the window. Here, patient may be in the window of the infection, still asymptomatic. Here, patient only IgG positive, means patient in recovery phase. Here, IgM positive means patient in early phase of infection. But last one, IgM, IgG positive means patient in active phase of the infection. طيب, what about laboratory findings? We have to do CBC, LDH, CK, troponin, liver function test for most of the patient, and طبعا sure the chemistry, basic chemistry. What we noticed that leukopenia is common, which is and it's around 30 to 45%. With lymphopenia more common, most of the patients are lymphopenic. It's around 33 to 85%. Some patients have thrombocytopenia. Some patients have high liver function test and high LDH, high C-reactive protein. Why we are ordering these laboratory result tests? Just to see what is the poor indicator. This is one of the poor indicators for the patient with COVID-19. We are ordering also D-dimer when you have, because D-dimer is as inflammatory markers, and when you have the high D-dimer, higher D-dimer is correlate with severity of the disease and correlate with mortality. But C-reactive protein is not correlate with the mortality. This is the poor prognostic indicators. It's I think explained before for you. Some is epidemiological, some is vital signs, some of them are labs. As we see here, the labs, D-dimer more than 1,000, C-reactive protein more than 100, LDH more than 245, elevated troponin, ferritin more than 300. These are the poor labs indicators, factors, or indicators, poor prognostic. And respiratory rate, when you have more than 24 or higher rate, means when you have these indicators, better to refer patient to the ICU because maybe patient will deteriorate. And I think indication for referring to ICU when patient have, most important, increasing work of breathing, when the patient is severely dyspneic or tachypneic or requiring a higher oxygen requirement by face mask more than 10 liters, then the best is to refer to the ICU. Maybe patient need to be intubated at this time. Maybe need intubation. And early intubation is better than late intubation because we are avoiding going to emergency intubation, which carrying a higher risk for exposure to healthcare worker. Here we can see that D-dimer, this is about the D-dimer. D-dimer usually started to elevate, highly elevated, around day 7 or day 8. And if it's elevated, it's, as we say, it's correlate with mortality. Right. Is there any index for the predicted of the severity of the COVID-19? Yes, there is what's called COVID severity index. It's the equation neutrophilia lymphocytes ratio multiplied by CBR multiplied by D-dimer over 10,000. If the severity index is between 0 and 5, patient is having mild disease. If the severity index between 5 to 20, he should be as inpatient. But if it's above 20, then this indicates patient should go to the ICU. What is the recommendation for management of hypoxemic respiratory failure in those patients? Oxygen to be given by nasal cannula or simple face mask or random breathing masks. Please avoid ambu bagging on those patients. Avoid non-invasive mechanical ventilation. Avoid emergency intubation. When you are planning to intubate patient, use the rapid sequence intubation. Avoid ambu bagging, and use the direct, use the video laryngoscope, glidoscopes when it's available. Why? We need to avoid the direct laryngoscope because we need more distance between the healthcare worker who is intubating the patient, which is better to be done by using the video laryngoscope. Use the box of intubation. It's available in our hospital now. proning position is important. Even if patient still not intubated, you can ask the patient to lie down or sleep on his abdomen. It will improve the hypoxemia, and ECMO can be considered in selective cases. But in disaster, when you have a lot of patients, rush of patients, ECMO doesn't have a rule because need more team, more time. Special cases needs ECMO when you decide that patient have refractory hypoxemia while he's on higher setting on mechanical ventilation, and you refer the patient to the ECMO team, and they are the one who decide to put patient on ECMO or not. Last questions, and I think last slide. 55, this is a clinical scenario. 55 years old male. This is the pooling, who is hypertensive and came back from Italy 1 week back, and he denied any contact with the COVID patient or sick patient. And he came with the dyspnea, severe hypoxemia, saturation 90 on respiratory rate, on room air, and respiratory rate is high, little bit, febrile, 38.9. What is your action for these patients? You did nasopharyngeal swab and it came negative, and chest X-ray normal. What is the answer here? Is it A or B or C or D? Okay, still, please, all of the candidates can answer these questions. Yes, number 1, A, reassurance and prescribe paracetamol antihistamine, or order home isolation, or admit to the hospital isolation room. Still waiting. Only 46% of the candidate, the answer, they voted. Please, we need more than 50%. طيب. Okay, we'll stop here, Ahmed. Okay. Okay. The answer is 78% answered C, and 13% answered B, and 9% answered D. Okay, the correct answer is C. Admit him to the hospital because this patient is hypoxic and need oxygen. He is highly febrile. He is highly suspected of COVID-19 because he came from endemic area and he's unstable. Regarding swab negative, you have to repeat, as we say before, and repeat the nasopharyngeal or order the oropharyngeal swab also. Requesting CT scan, it depends on the, as we say before, on the treating physicians. But as we say, because this is early stages, you can early diagnose the patient with CT scan if, because the swab was negative initially. If you have bilateral ground glass appearance, means this patient is most likely having the COVID, and you can start the treatment immediately with hydroxychloroquine and azithromycin. Thanks for your listening. I want to hear questions from the audience, please. This is the capsule. Who did see the capsule? This is the capsule for transporting patient to other hospital. We will put the patient inside and we'll transfer the patient inside this capsule. Yes. Dr. Agultakin, any questions?
Thank you, Dr. Ahmed, for a very comprehensive lecture. Any questions, please?
Let me review the chat. Maybe there is some questions missing in the chat initially.
When you suspect PE in COVID-19.
When you will suspect,
PE
yes.
in COVID-19 case.
If you have a patient who is intubated and having a very high D-dimer with unexplained hypoxemia, even by X-ray, then you have to think about the BE, and you can do the echocardiogram for the heart to see the right side of the heart, and you will start the therapeutic Clexane immediately and send patient to for CT angio or spiral CT, as we say, to rule out BE. By the way, BE is common in patient who is having COVID. That's why we have our protocol for starting, especially for COVID patient, for anticoagulation. When you have 6 times fold positive higher in the D-dimer, you will start patient on therapeutic anticoagulation. Then you will minimize the dose according, or adjust the dose according to the creatinine clearance for the patients and according to the weight. Any more questions?
There is question regarding the, as I understand, a patient with COVID positive who is asthmatic and corticosteroid you use in those patients.
Yes, as we said before, corticosteroids is not indicated in COVID patients unless you have another solid indications like bronchial asthma, COPD patients, very severe ARDS, then you can add the corticosteroid. Otherwise, it's not indicated. Dr. Bashir, I think the previous lecture, he explained about that in details.
Any other question, please?
Thank you, Dr. Agultakid. Thank you for all. I hope everyone you will do the best in this pandemic and disaster time. Thank you.
Thank you, Dr. Ahmed.
Thank you. Yeah.
So thank you, everyone. Inshallah, see you tomorrow.
Okay. Thank you too much. Bye-bye.